Welcome back to day 2 of the Health Policy Commission's 7th annual cost trends hearing. You all came back. I'll take that as a good sign. It's dry in here. I was going to say it's warm, but we'll check the temperature at the end of the day. I think yesterday was a insightful discussion. More to come today. I want to jump right into it. It is my distinct pleasure to introduce our first speaker. Having the benefit of working in the Metro West region, I've gotten to see firsthand Senator Spilka's work to improve access to health care, especially mental health and substance abuse services. She is truly a tireless advocate for children, people with disabilities, and older adults. It's my pleasure to introduce my friend, Senate President Karen Spilka.
Good morning.
Morning.
Thank you, Marty, for that kind introduction, and I could say back at you. Seriously, thank you. Thank you for inviting me to speak here today. It's great to see all of you. Thankfully, I stayed in town, so I did not deal with the traffic that I'm sure many of the folks here and some that are still sitting in traffic are experiencing. I'd like to thank the Health Policy Council for the work that you've done to monitor and analyze healthcare spending so that we can have a better understanding of how we're doing as a state and better inform us in the legislature. I'd like to thank GIA for its work as well, and I'd like to thank Governor Baker as well as Secretary Mary Lou Sutters, somebody I've worked with for many years in other capacities as well, for the thoughtful health care bill that was released by the administration last Friday. Thank you. I'd like to also thank the administration's commitment to keep mental and behavioral health at the forefront of any discussion about health care. I'd like to also thank my friend and colleague, Speaker Bob DeLeo, for his partnership in these areas on these important issues, and extend my thanks to Attorney General Maura Healey, who I know you're hearing from after me, for her really strong diligence and passion in fighting the opioid crisis and protecting our young people from the harmful effects of vaping, among other things. Healthcare access and affordability has been a long-standing priority for the Massachusetts State Senate, as you know very well, David Seltz, beginning with the reform in 2006 and continuing to the present day. And so I'd like to take this opportunity today to give you a sense, just briefly, of what we've done, what we'd like to do, and where we see an opportunity to make a transformational change. Most recently, the Senate, House, and administration came together to pass the most comprehensive supplemental rebate program in the country in the fiscal year 2020 budget. Under the leadership of Senate Ways and Means Chair Michael Rodrigues, we also made significant major investments in many areas of mental health, behavioral health, and substance use disorder, nursing homes, and aging at home, and protecting children's health, among other things. In 2017, the Senate passed the Health Act, driven by the work of a year-long, it was over a year actually, effort, which I know some of you participated on, by the Special Senate Committee on Healthcare Cost Containment and Reform, which I was active on, to analyze best practices in other states and engage many, many stakeholders. In that bill, we focused on bringing our healthcare delivery system into the future by leading the way on telemedicine and mobile integrated health, while also, I believe, we found ways to reduce costs. Our work on these areas continue to this day. The Senate Chair of the Committee on Healthcare Financing, Senator Cindy Friedman, who is with us today, is currently working on a number of healthcare initiatives, including a bill to control the cost of prescription drugs. And we continue to look at other issues, such as surprise billing, out-of-network costs, and scope of practice. Maybe this year will be the year, or this session, that we finally get some scope of practice. Inspired by the work of the Health Policy Commission, we have begun to look at the cost of insulin in particular, which constitutes a tragic barrier to care for diabetes patients, according to Robert Gabay, the Chief Medical Officer of the Joslin Diabetes Center in Boston. The idea that diabetes patients who have access to life-sustaining treatment must choose between that treatment and paying rent is just unacceptable, especially here in the Commonwealth in 2019. It's beyond the thought that somebody would have to make that choice. Where you can't turn on a radio or open the newspaper without hearing of the latest technological innovation in healthcare, thanks to our incredible research institutions and companies here in Massachusetts. But it's also becoming increasingly difficult to turn on the news without hearing stories of individuals, families, and communities in crisis due to either the lack of access or lack of affordability in some step along the way in our healthcare system. And that also is just unacceptable. We can and must create an innovative healthcare infrastructure that provides accessible, affordable, quality level of care for all of our residents and all of our healthcare needs, while continuing to provide an environment where research and development and technological innovation can thrive. We can do that, I believe. The annual HPC cost trend hearings have provided an invaluable opportunity for raising, sharing, and advancing ideas that have become important to our ongoing discussions around healthcare. And that's why I'd like to take just a few minutes of the time that I have remaining to raise a topic that, for me, is a personal priority, and one that I think can have a very profound impact on our residents. And that is the idea that any comprehensive healthcare delivery system that we create in the coming years must include mental and behavioral health as integrated components. And that's a key word, integrated. Many of you may also know that my father struggled with severe mental illness. What you may not know is that I didn't talk about it until after I became a legislator. I very readily talked about my sister with Down syndrome. That was more accepted, but I didn't talk about my father because I was too afraid or embarrassed to talk about it and the effect on my family. For too long, we have treated the subject of mental illness as something to be ashamed of, and that has just prevented us from making sure that our residents get the help that they are entitled to as part of routine health care. It also means that we have not taken an accurate measure of the impact of mental illness in all of its forms, along with the associated effects of these diseases on the cost of our healthcare system and our state as a whole. But from what we do know, the numbers are staggering. According to the National Alliance of Mental Health, NAMI, 1 in 5 U.S. adults experience mental illness each year. That is a staggering number, 1 in 5. Across the U.S. economy, serious mental illness causes with an estimated $193.2 billion in lost earnings every year. with the number going as high as $300 billion each year if you look at all of the health and wellness concerns. But when you look at the systemic effects of untreated mental illness in our Commonwealth, the numbers grow even larger. If you believe, as I do, that much of the opioid epidemic is the result of unmet mental health needs, we lose $2.7 billion a year in business productivity from employees suffering from opioid addiction, according to the Mass Taxpayers Foundation. Mental illness and substance use disorders are the cause of countless emergency room visits, acute hospital stays, and comorbid conditions. They also account for lost productivity at work and higher health care costs for employers. Beyond our healthcare system, the prison system is now one of the largest providers of mental health in our state. And untreated mental illness is a big cause of repeated incarceration. 37% of incarcerated adults have a diagnosed mental illness, and tragically, over 70% of youth in the juvenile justice system do too. There is virtually no area of our economic, civic, and personal lives that is not touched by the need for mental and behavioral health and wellness. And so we must take the integration of mental and behavioral health into our healthcare system to create one continuum of care, and we have to take that seriously. The Senate, under the direction of our Senate Chair of Mental Health and Substance Abuse, our great Senator Julian Cyr, is currently taking a close look at ways to do that, working with our other great Senator of Healthcare Finance, Senator Cindy Friedman. In addition, the Senate recently dedicated $10 million in the 2020 budget in new funding to support our efforts on mental and behavioral health. In addition to increasing many, if not all, of the line items for behavioral health and addiction, we created this $10 million reserve so that we can use it for some immediate needs, and then also as we pass some bills, we'll have that so we can start the programs immediately. So we will use these funds to expand access to services for every region for all residents. Regional equity is also very important. We will increase the number of well-trained practitioners through workforce development programs and examine ways to utilize technology such as telehealth to increase access to especially underserved areas. Most importantly, we will tackle how to reduce the shame, silence the stigma surrounding mental illness and substance misuse through a public education campaign that centers the voices of those most affected, as well as work towards achieving true mental health parity, which we feel is crucial to our efforts to provide access and reduce overall costs. I am very proud to have both Senator Friedman and Senator Cyr continuing to work on these issues of parity, stigma, and the surrounding issues. And I hope and invite all of you to join our efforts to end the stigma. We need your voices as well. Because ultimately, this is more than just the bottom line. This is about people's lives. And we know that the next healthcare challenge is just around the corner. And we also must anticipate that the next big mental health care challenge is just around the corner as well. We must create a healthcare delivery system that can not only head off rising healthcare costs, but mitigate or even prevent the next addiction crisis. This is Massachusetts, and after all, it's the hub of innovation in technology, in healthcare. I think I'm a little biased maybe, but we have the smartest minds in the country here. And so if any state should be able to figure this out, a way to reduce the stigma around mental illness, create true mental health parity, and build a comprehensive, integrated, and affordable healthcare system, I believe it's Massachusetts. I look forward to working with all of you to reach these important goals, and I thank you for your continued good work and for inviting me here today. Thank you.
Senator Spilka, thank you for just heartwarming, compassionate remarks, and for your ongoing commitment to behavioral health. I know on behalf of my fellow commissioners and the staff of the commission, we look forward to continuing to work with you and Chairwoman Friedman in this coming session to really, I said yesterday, this is an inflection point to move that point forward. Thank you.
Thank you. Thank you.
We have a few minutes before our next speaker arrives. I want to just ask for some sort of reflections from yesterday's discussion. Dawn and Chris, you both led the panels on prescription drug costs as well as on administrative complexities. Some reflections from yesterday?
I'm thinking.
He's reflecting.
Yeah, well, I'll start. I said what I thought at the end of the session and welcome comments from other co-commissioners. We have a very serious cost problem in this Commonwealth. It's hurting individuals, especially out of pocket. And so anything we can do to reduce non-value-added activity, waste in the system, isn't a matter of leisure, it's a matter of urgency. And the evidence is overwhelming that the complexity we examined during the panel that I got to facilitate is one focused large area of total waste. We heard the stories from small business, from doctors trying to do their work, from hospitals about a kind of burden. And what strikes me is how easy the problem is in some ways. You look at the nonsense around the pre-authorization stories, the stories of paperwork, the stories of coding games, the stories of complexity of coding, and you say, why wouldn't a rational person just change it? So we're having trouble being rational. And as David said, and I said, and Secretary Sutter said, we've heard this conversation for decades, and it hasn't been fixed. And I mean, I'm trying to be a nice guy, but it's like we owe it to the public to do something about this. And if the private sector can't get its act together to do it on a voluntary basis, we have to work with the legislature and the governor and try to make it happen for real. This is just waste the Commonwealth cannot afford. That's my belief.
Well put. Chris?
So it's interesting that pharma and drugs and retail pharmacy is far less administratively complex than everything, certainly than the mental health integration that Senator Spilka just talked about, because they're discrete items, they're pills. There's a cost per pill, and our panel yesterday, I thought was not defensive in contemplating how changes could occur in transparency of pricing and trying to contemplate ways to reduce the cost of drug development, taking advantage of expertise that resides here in Massachusetts. So in theory, it's an easier place to go than administrative complexity in general. And I wonder whether we can't take advantage of the bonhomie among payers, manufacturers, and retail and insurers, and try to convene a little more so that maybe we can accomplish something. Dr. Brennan mentioned The, you know, there was notwithstanding the, I don't want to make it sound like it was simple. I mean, rebates are opaque and a source of frustration, I think, for all of us, because we can't see the programs behind those rebates that may or may not have value. So I don't want to suggest that it was that clean and that simple. But in that conversation, Dr. Brennan went to transparency of pricing and you know, slipping an app into the electronic medical record so physicians or nurse practitioners could tell their patients, well, you know, what the retail cost was going to be. You know, that's a pretty that's doable. We're not talking about, you know, integrating systems here. We're talking about an application that you add on to an interface with existing systems. So I thought that there was some positive that came out of the pharma discussion, and maybe we should figure out how to continue to convene the various constituencies and say, okay, you talk big, but what can you do?
Just my own reflection from yesterday, picking up on Don's point, I on the way home kept thinking about the word will, and where is the will to really change things? We hear a lot about strategy and a lot about you know, how the system has so many moving parts, but I didn't hear a lot about the common will to really move things forward.
Okay,
So,
understand.
yeah, Mary Lou.
So I didn't hear a lot about the ultimate goal of healthcare is better health for individuals. And I sort of lost the word consumer in the process. I didn't lose it. It was not really said by much. And I was really sort of stunned by that on both panels, honestly. It was around what you'd say, strategy and things. And I think there's perhaps goodwill at the table. I didn't see the will to change. I think people are good at identifying the problems. I just don't hear the next step and sort of what's the benefit. On the pharma piece, it was like, great, so there's nice contracts between the drug manufacturers and the payers and the like, but like, what's the benefit to the consumer? And we just heard from the Senate President using insulin as the example, and there's lots of examples out there. So I just, like, what's the benefit to the end user who's paying the premiums or the Commonwealth in terms of Medicaid? So I just, maybe today's, we'll hear the word individual, consumer, patient, client, whatever term of art people want to use these days, a little bit more as the center of these conversations.
May that be a clue to our panelists and presenters.
Just saying.
I know our next speaker is here, so without further ado, I want to turn it back to Don Berwick to introduce our next speaker.
Thanks, Mr. Vice Chair. So it's a real honor and privilege for me to get to introduce Attorney General Maura Healey. General Healey was sworn in as AG on January 21st of 2015. She said at the time she was going to lead the People's Law Firm, and that is what she has done. She's tackled issues all over the palette of issues that affect people in Massachusetts, and I must say nationally, including the heroin prescription drug abuse epidemic, escalating healthcare costs, worker rights, student loans. She's focused on improving consumer protections, improving criminal justice. I find it difficult to think of a single issue in the progressive frontier or the frontier of social justice that Attorney General Healey has not become not just a leader in the state, but a leader with her voice and activities nationally. It's a real privilege to know that she serves our Commonwealth. She launched the Consumer Engagement Division in May of 2015. That's the first of its kind division in an Attorney General's office, and she continues to find new pathways to help achieve the justice we want. She's been an outspoken advocate in the environmental and climate arena, both in the state and nationally. So we're very, very lucky to have her. And General Healey, thanks so much for being here. We're looking forward to hearing your remarks.
Well, good morning. Thank you very much, Dr. Berwick. And thank you to the entire commission for the work you do. It's an honor to be able to appear before you once again with my team, who most importantly you'll hear from shortly. But to that end, I do want to acknowledge and appreciate as well the work of Secretary Sutters and her team in the administration. We're working together on a lot of fronts these days. But to David Sells, Ray Campbell, the entire staff and teams at both the HPC and SHIA, thank you for the work that you do. And to all of our commissioners, I thank you for your commitment and your work to improve healthcare for residents across Massachusetts. I want to introduce members of my team, though I think you're familiar with all of them. Eric Gold, of course, is chief of our healthcare division. And with me today, who you'll hear from, Amara Azubuki and Noam Yosefi, who will be presenting. You know, I guess I want to just acknowledge at the outset, we continue to work hard on matters related to the opioid crisis. I want to thank everyone in this room and many behind for the support you've given my office, both in litigation and enforcement matters, but also as we think through our own policy initiatives and actions that we need to take. And I think it's been a very important opportunity for collaboration and teamwork and bringing to bear best thinking and strategy. It's also brought into sharp focus, at least for me, the significant need for behavioral health services in our state. That's not unique to our state, but I will use this morning to just make an additional plug that certainly any recovery we make in these matters, I know you'll support me in wanting to see that go towards treatment and care. I've been spending a lot of time in schools. I like to do that. I'm out in schools, middle schools, high schools. And one thing that becomes clear to me as I sit and listen to students, we've been doing some work around gun violence and some work around health and wellness, is the need for behavioral health services, the wait times across districts. And it doesn't matter rich, poor, the wait times are really astounding to me as somebody who is not in this field, and I know you're all too familiar with this. So whatever we can do and think about locally and as a state to better provide greater behavioral health resources for our young people, I know will redound to the benefit of not just those young people, but all of us in time. I also want to just comment too, we are in court, as you know, defending the Affordable Care Act. Recently this summer, a 3-judge panel in the Fifth Circuit Court of Appeals in New Orleans heard argument on the constitutionality. We filed an appeal following an adverse ruling, joined by 20 other states. We are awaiting a decision, and I know we will work collaboratively to figure out as a state the path forward, no matter what happens, appreciating the stakes and the importance of ensuring that folks continue to have access to the care that they need. And speaking of other litigations, touching briefly on vaping, we're actively defending the governor's ban on vaping. We are in court this week and we'll be in court next week. But we know and recognize the serious issue here and the need to address death and serious respiratory and pulmonary disease caused by these products. Necessary to take the time to understand what's happening. My office continues to investigate the e-cigarette companies that we sounded the alarm on well over a year ago, recognizing that this was becoming more of an epidemic among young people across the state. And I encourage continued efforts, both as a matter of policy and law, to address the dangers and harms of that industry. But now it's my role to introduce our findings. Each year we endeavor to put forth something that might be constructive, though I came in at the tail end of Secretary Sutter's comments about solutions, and I do not purport to have or offer any solutions.
Me either.
Merely further identification of problems. But I'll get right to it. Look, when we know that when it comes to ensuring access to healthcare, Massachusetts has led the way. Our hospitals, doctors were world class. We're the first, proudly, to have universal access to healthcare, and our exchange became the model for the Affordable Care Act. But we know we have more to do in this state. Massachusetts families and our small businesses are spending more on healthcare than ever before. In 2018, total healthcare spending grew 3.1%, and the average monthly insurance premium is more than $500 per month. Increasing numbers of residents have high deductible health plans, which means paying potentially thousands more out of pocket each month. This year's report, my office found through our review that 2 key initiatives that have been put in place to control costs are not doing enough to keep healthcare costs down for Massachusetts residents, consumers. First, the online pricing tools that allow patients to choose lower cost providers by comparing the price of services from different doctors and hospitals just aren't having the promised consumer impact. Second, we analyzed the alternative payment arrangements, and we found that these arrangements aren't controlling costs as well as they could because they're too complicated, and consumers frequently switch health plans. So the bottom line is we can be doing more. While price transparency for consumers is essential, we have to find a better way to establish real incentives for delivery of high-quality, low-cost care. And as part of this effort, we should encourage consumers to select primary care providers with a record of keeping costs down. I think we also need to take a close look at the incentives for healthcare providers to direct patients to lower-cost healthcare settings. Tinkering at the edges is unlikely to make any meaningful difference. So as I turn it over to our team, let me suggest that our report is a further call to action to return to ideas and solutions that will help ensure the accessible and affordable healthcare system that our state, our businesses, and our residents deserve. And again, I appreciate the opportunity to appear before you this morning and appreciate the opportunity for further collaboration on any number of fronts as we move forward in this state. Thank you, and I'd be happy to take any questions.
Thank you. Thanks, General Healy. We look forward to hearing from your team, but maybe people do have some questions they'd like to address directly to you.
I just want to thank you for the superb defense, both in terms of the opioid epidemic and most recently on vaping. We're not trying to just keep your litigation team, in the Full Employment Act, but truly just really have appreciated the partnership on representing us, and particularly on the opioid epidemic, but certainly on this most recent, the vaping, and we'll see what happens in court next week. But just really want to thank you for that.
Well, thank you, and I'll take that back to the team who will appreciate that.
Yeah.
Thank you.
Chris?
Attorney General, can you take us down the track of the different forks? If the ACA finds another adverse ruling, there'll be presumably time before it goes to the Supreme Court. How do we, as Commonwealth, build a safety net around that?
Well, I think that, any number of folks have given thought to that. We've had to deal with some scares, too, in the interim, whether it was threats to cut off Medicaid funding or coverage for contraception for women's health care. So I think, we have some ideas, Chris, we really do, but I think we've got to wait and see. It's hard to say what this Fifth Circuit will do. No doubt this will land in the Supreme Court sometime this term. And I think depending on the rulings, I think we have a great base here. I am mindful, though, that, and I've tried to say this to people, I think I'm right in saying this. While we have terrific, access to care here and universal coverage, the disruption to the market nationally will have ramifications, and people behind me can better address that. But, that's also a point we've tried to make, recognizing that, those actors are going to be impacted as well. But know that my office will continue to be in close contact and collaboration with the Executive Office of Health and Human Services and others to think through what exactly we need to do to shore up and maintain support, and I think continue politically working with our congressional delegation and others, as I know this will continue to be an issue as we move through 2020. But I'm happy to, if you or other commissioners have ideas, specific concerns, I know Mary Beckman, our wonderful Healthcare Bureau Chief, is here. today and would be happy to talk further.
Thank you.
Thank you.
Could I ask, I'd like to ask a question. Senate President Spilka was here just before you and spoke, as you did, about the mental health and behavioral health. She mentioned the criminal justice edge of that, how much of the justice system is actually a mental health system. Could you just quickly, where are we on that, and where would you like to see the Commonwealth go?
Well, I appreciate that in the governor's recent proposal, there is fair attention paid to behavioral health services. I think that's terrific. I think these things go hand in hand, and we need to support providing behavioral health services across a range of venues, including, in our jails and prisons and within the criminal justice system as individuals come into the criminal justice system. So I think that there is a recognition that is incredibly important, that so much of the violence that occurs is trauma-informed. Trauma creates more trauma, and violence in it. We see patterns replicating. The studies bear that out. But what I see is just a dearth of services. So somebody may appear at arraignment. You may have somebody in the court system, looking to find that individual a bed, looking to find services for that individual. It is incredibly hard to navigate that, both, I think, because there's just not enough by way of services. And I've said we should have a Peace Corps in this country to get more healthcare providers, behavioral healthcare providers out there. I don't know, but I feel like, if I'm hearing from, young people who need care, that there are 6 and 9 month wait times in their school districts, you think about the life of a child and what that does to them. So yes, we need it in the criminal justice system. I do think that fundamentally we face the same challenge there, that there simply aren't enough providers out there for people to be able to access them. It's just hard and complicated. I was up in North Adams not too long ago. I was at Drury High School, and we were having a discussion about our program, Sandy Hook Promise program, where we're in schools and young people are sort of being taught the both how to say hello and be kinder to one another, more inclusive, but also to recognize the signs, the warning signs of depression and the like. It's a really powerful program that Sandy Hook Promise has put together. We got a grant of $1 million from the feds to bring it to the state. But we were in a roundtable discussion with young people, and I asked the question if any one of them had, if any one of them knew a peer who tried to harm themselves. Every single hand went up in that room, every single hand. And I just think it speaks to, a snapshot of the need that's out there. And, these are kids who, you think about who ends up in the criminal justice system. There are all sorts of reasons why people end up there. But if you walk into any district court this morning, you're going to know that 80% of people who are coming through the door are presenting with substance use disorder, mental health issues, right? And so I just think the more we can do there, the better off we'll be. But I do put an emphasis now, having been out and about a little bit more these last few years, on getting access to those services for young people. It's a long answer, but I just wanted to share that vignette because I was really, really struck by that response.
How old were those kids? Was that high school?
Yeah, they're all high school. So it was freshmen to seniors. It was freshmen to seniors. And now the good news is, one of the girls who spoke very openly about her early trauma talked about the fact that this program in school was going to perhaps provide a different experience for a 12-year-old today, different from the experience that she had. And so she was grateful to be part of that program. And so there's a lot to be optimistic about. Our young people have the willingness, they have the desire, they have the engagement, the capacity. We see that happening, all over as they take to the streets or walk out or speak out. But I think collectively, we have just got to find ways to provide more.
Thank you very much.
So
Any other?
one of the ironies is if you go onto, and I say it to you, but to everyone. So when you go into the national data, Massachusetts has the greatest number of behavioral health licensed practitioners in the United States, only half of whom will accept any insurance. So, I mean, we, right, Marty and I will, and so it is just one of the things is we try to put out some ideas in the governor's healthcare bill around that, but it's just one of those, it's just one of those facts that is like, as a social worker, as a licensed social worker, is like just, of which none of you would want me to be practicing again, I can assure you that. It is just one of those ironies, is like, how do we either make it acceptable, deal with the barriers, the insurance barriers, and all the other things to sort of increase access, exactly as you put it.
Yeah,
So
well,
it's just
I
something-
really appreciate your focus and advocacy
time.
around that.
Yeah, thank you.
Any other questions for Attorney General?
Thank you so much.
Thank you.
Thank
All
you
right,
so
thank
much
you
for
all
being
very
here.
much. Okay, so we're going to now be joined by our Assistant Attorneys General, Amara and Noam.
Thank you, Attorney General Healy, and thank you, Commissioners and HPC staff for inviting us today.
We have our
My
slide
name,
deck.
oh, yeah, sorry, the clicker.
One clicker free.
So thank you again, Attorney General Healy, and thank you, Commissioners and HPC staff for inviting us here today. My name is Noemi Sofia. I'm a healthcare analyst, and I'm joined by Assistant Attorney General Amara Azubike. As you know, our office has its unique subpoena authority to examine market trends and report on our findings since 2010. Prior reports have documented provider price variation irrespective of quality. Last year, we reported on administrative complexity associated with commercial payment methods and how this adds costs and makes it difficult for market participants to choose cost-effective options. This year, we looked at 2 cost containment initiatives, consumer-facing price transparency and alternative payment arrangements, and examined whether these efforts have influenced patients and providers to select high-value care options. First, I'll discuss our examination of Massachusetts payers' online cost estimator tools. Then Amara will discuss our provider incentives under alternative payment arrangements. Then Amara will present our findings on the change in inpatient expenditures at lower-priced hospitals compared to higher-priced hospitals, and she will conclude with our recommendations. So we reviewed the online cost estimators of 6 payers, the 3 largest payers in Massachusetts, 1 national payer, and 2 small regional payers. These websites provide patients with estimates for services across providers and care settings to encourage market-driven cost containment. This slide shows usage rates for 4 of the 6 payers' cost estimators displayed as the number of searches for every 100 members. We obtained every single search that was generated on these payers' tools from 2016 to 2018, and across the board, consumer use of these tools was very low. Even for the payer with the highest rate of use, only 7 searches were generated for every 100 members. This is true even though many consumers are overwhelmed by the healthcare shopping experience, as Amy Rosenthal of Healthcare for All testified yesterday. Along with usage rates, we also identified some commonalities. For all 6 payer tools, consumers can log in to find out how much a service will cost, including facility fees, co-payments, and deductibles. None of the cost estimators account for non-claims-based payments, which are quality and efficiency bonuses associated with APMs. If the market indeed shifts away from a fee-for-service framework, then cost estimators that rely on historical fee-for-service claims will no longer be relevant. Although we did not examine the tools for accuracy, cost estimates generated by payer tools are required to be binding. And none of the cost estimators reference this consumer protection, and most have a disclaimer stating that estimates may not be accurate.
Can we interrupt you with questions?
Yeah,
as you go? The adjustments, are the adjustments involved in the patient copays? So I thought the copays were generally done prior to whatever post hoc adjustments there were for quality metrics and so on. So they wouldn't be relevant for the patient payment.
Right, right. So the estimate reflected towards the patient would not capture those
Right,
those bonus
right.
payments, right?
Okay.
Can I just ask one quick question? How many languages are the website tools available in?
Yeah, so we found that all of the payers but one offer the tool only in English, with one tool offering in Spanish as well. So we see that as a significant barrier to access to this tool. So we also looked at demographic and market segment data, including searches by members in high and low deductible plans. This slide shows our findings on tool use by consumer deductible level between 2016 and 2018 for one Massachusetts payer. Members in high deductible plans had double the search rate of members in low deductible plans. And this finding shows that financial exposure impacts consumer use of these cost estimator tools. Still, it is important to remember that the opportunity for cost estimators to reduce spending among even this group is limited. Patients in high deductible plans are no longer financially incentivized to select a high-value provider once their deductibles are met. And this is especially true for high-cost patients with chronic illnesses, who represent 20% of patients but account for nearly 80% of healthcare spending in the Commonwealth, as we previously reported. These patients are certain to reach their deductible, irrespective of how prudently they shop for care. This slide shows the most frequently searched and total number of services available on each payer tool in 2018. The total number of searchable services varied significantly, ranging from 105 to over 1,600 services. Members generated the most searches for imaging services, followed by physician office visits, pregnancy procedures, colonoscopies, and elective surgeries. Most of the frequently searched services are not the main drivers of rising healthcare costs, and as such, increased shopping activity in these areas may not significantly contain costs. Notably, we found that none of the payers integrate pharmacy prices into their tools. Though only 3 of the 6 payers include behavioral health services in their cost estimator tools, we found that when included, they're among the top search services. Payers indicated that some consumers access their websites in order to find a doctor. And as a result, payers have embedded their provider directories into their cost estimator tools. While we did not assess the accuracy of these directories, we suspect that the volume of behavioral health care searches may relate more to the documented need for a behavioral health care provider than it does to consumer price sensitivity.
Thank you, Noam. Now I'll turn to our analysis on incentives and alternative payment arrangements. First, I'll discuss our findings on patient movement across payers and products. Then I'll discuss variation in how PPO patients are assigned to providers for the purpose of APMs. This slide summarizes our findings on how many patients switched payers and insurance products over a 2-year period. To measure this, we received member rosters from 3 Massachusetts payers associated with 12 large provider organizations. The 3 colored lines represent the 3 payers. The vertical axis shows the percent of members enrolled in each plan from January 2017 to December 2018. The month of January is used as a baseline. That's why membership in January is at 100%. For payers A and B, 43% of members moved either out of their health plan or out of their product in that time period. Payer C experienced a 56% rate of attrition. Most patients who switched payers or products did so in January or July, months in which most policies renew. For this examination, we did not examine changes in patients' relationships with their providers. However, patient movement across payers impact provider incentives to invest in population health because different payers and products include different incentives. APMs give providers financial bonuses or penalties based on their ability to provide high-value care to attributed patients. These incentives are product-specific and are specific to specific patients. When patients move frequently between providers, when patients move so frequently across payers and products, providers could not be certain they'll receive the financial benefits from APM investments. For instance, when a patient changes her payer or product, she becomes associated with different payment terms. She could now be in a fee-for-service arrangement with no provider incentives, or she could be associated with another APM, which rewards her based on an entirely different set of benchmarks. In this scenario, the provider would not know whether her investment led to better outcomes as measured by the APM, and it's also unclear whether another provider would subsequently earn a bonus for an investment that they did not make. This chart summarizes the different ways the 3 largest payers attribute PPO patients to providers for the purpose of APMs. These payers use different and complex attribution methods. One payer attributes patients to PCPs only, another attributes to specialists, and payer C attributes patients to nurse practitioners, physician assistants, and to physicians. Some payers only assign patients who are Massachusetts residents, and one payer considers only outpatient claims originating in Massachusetts for attribution. Payer B excludes all inpatient and outpatient behavioral health claims from attribution. All payers attribute patients retrospectively, so providers may not know which patients they are responsible for until after they've cared for them. A patient may be attributed to a provider who cared for that patient only one time up to 27 months ago, which demonstrates the fragile link between an attributed patient and their responsible provider. Our interviews with payers showed that retroactive accountability for a constantly changing population is complex and adds administrative costs. Both providers and payers employ staff and systems to identify and account for the variability and the fluctuation. We did not identify evidence that this kind of administrative complexity adds value for patients, providers, or for the payers. An important goal of recent cost containment initiatives is to shift healthcare spending to higher value providers. To explore the impact of cost estimators and APMs on meeting this goal, we conducted a case study into expenditures at lower price hospitals compared with higher priced ones. This slide shows Blue Cross Blue Shield of Massachusetts inpatient expenditures for HMO patients assigned to 8 large provider organizations. The bars represent annual expenditures in 2014 and 2018. The blue portion of each bar represents the share of expenditures at lower price hospitals compared with higher price ones shown in orange. We define lower price hospitals as community hospitals with a CHIA relative price of 1.0 or below, and as AMCs with a CHIA relative price of 1.2 or below. As you can see, the share of inpatient spending at lower price hospitals decreased by 2.5% from 2014 to 2018. And conversely, expenditures increased the same amount for higher priced hospitals. This slide is a 2018 snapshot of inpatient expenditures broken out by the same 8 provider organizations. The share of inpatient expenditures at lower priced hospitals varied substantially across these provider organizations. For example, Partners patients received care mostly at higher priced hospitals, and Lowell patients received care mostly at lower priced hospitals. Through our examination, we found that the providers with the high proportion of expenditures at lower priced hospitals also often had a greater increase of the share of expenditures at lower priced hospitals from 2014 to 2018. Only 3 provider organizations increased expenditures at lower priced hospitals between 2014 and 2018. And 5 out of 8 of the provider organizations' expenditures at lower priced hospitals either remained flat or decreased. This suggests that cost containment initiatives since 2014 have not uniformly correlated with the shift of care to lower priced hospitals. Although this expenditure data doesn't explain the cause of any shift toward or away from lower priced hospitals, we found that when the composition of a provider organization changed to include a lower priced hospital, this change was associated with an increased share of spending at lower priced providers. This is important because with increased provider consolidation and alignment, more physicians are incented to refer patients to in-system providers, whether they're low or high cost. And since most consumers choose their care based on their PCP's advice, we should not expect consumers to meaningfully seek care outside of their systems. So based on these findings, we offer the following recommendations. First, we should manage expectations that cost estimators will substantially reduce healthcare cost growth. As Amy Rosenthal testified yesterday, consumer-centered education cannot change the marketplace. System changes are required. Instead, we should design tools that help consumers choose PCPs affiliated with high-quality, lower-cost systems. This is a just-in-time transparency described by Cheryl Corman of Middlesex Savings Bank yesterday. Despite limitations, cost estimators do provide important information for consumers as they navigate a fragmented system. The tool should be enhanced to focus on shoppable services. They should fully integrate behavioral health and RX services, and they should be accessible in languages other than English. Second, we should closely review incentives for healthcare providers to direct patients to lower cost settings. For example, APMs would likely have a greater impact at shifting care if providers took on sufficient downside risk. Third, we should recognize that providers' APM incentives are significantly hampered by frequent patient movement. Stakeholders should explore opportunities to align risk contracting terms so that even when patients switch plans, provider APM incentives remain consistent. And finally, there should be standard APM attribution methods to reduce administrative cost and burden. Yesterday, Dr. Afghan of Tufts Medical Center testified to the disparity of administrative costs in Ontario compared with hospitals here in Massachusetts. He emphasized the need for simplified payment structures between payers and providers, and we agree. So with that, we just want to say thank you for having us and for the time, and we're happy to answer any questions.
Thank you very much. Very clear. Do we have time for a few questions, David? Yeah. I'll ask one and then open it to my colleagues. For your fourth recommendation, the standardization one, which is consistent with our conversations of complexity yesterday, who has the authority to require standardization of attribution? Does that authority rest anywhere?
Well, that's a great question. So these attribution methods are actually come into play through payer-provider contracting. So they're bespoke, they're unique, and they're industry developed. So I would think it would need some action from either the legislature or the industry.
Thanks. Marty?
Great presentation, thank you. Amara, on the chart where you show the patient movement from in APM performance, do we know whether that's the consumer or the employer making the change?
That's a great question. So we don't know. We just looked at member rosters from the beginning through the end. However, studies do show that it could be based on leaving your employer or your employer switching the options in those time periods in January, July.
Yep.
Chris?
Yeah. Since those were two great questions, the pressure's on. Great question. And this is probably not a great question, but
Now.
the other, in the incentives category, you mentioned that PCP attribution is complex and raises administrative costs and hinders the incentives. The other thing that is apparent is that the incentives are really meager. And there's a lot of national literature about physician-directed ACOs being much more able to increase quality and reduce cost. Who has the authority, I think it's legislative authority, to set different thresholds for incentives? So, for instance, the governor's bill we heard yesterday is proposing to shift increased activity of 10% a year, 30% in 3 years, I think it was, for primary care and behavioral health. Is there also a plausible strategy to increase incentives to manage those patients? Because the other fact, I think, well, actually I know this, is that while there may be churn of 50% every 2 years between payers, the churn from physicians is far less. So shouldn't, from a policy standpoint, we be pushing more and more for higher incentives and for physician-directed ACOs?
That was also a great question. Thank you. I would say, yes, we should be pushing for it in terms of who has the authority. Once again, these are payer-provider contracts, and I think the legislature would have to, may have to step in if it doesn't happen through the industry.
So I'm going to ruin the string of good questions. I assure you. There's an issue in which relates to our earlier discussion, and Don brought it up, which is that a lot of what we do as a commission is sort of provide information about things and occasionally make recommendations. So we provide information about things that are not working well and things that we think could work better and so on. And then and occasionally we make recommendations to the legislature. And I think some of what's coming out in this discussion, as it came out in the earlier discussion, is that we think that that's sometimes not enough. that just making recommendations is not working, that just saying, well, it would be good if they harmonized on this, because they've known this for years, that these have been off and that they're not harmonized and so on. And so I think it's pushing us to the edge of thinking about what does it mean to go beyond just providing information and pushing, but into how strongly we're going to push, what is it that we are going to think about doing. And so I suspect that that's a conversation that we as a commission need to have over the next little bit, because there's just a level of frustration that builds up when you sort of see these things continuing to go on and you don't see progress being made.
I think that was a great comment.
I'll give you an A in class.
Actually, building off of that, a number of the major health plans and provider organizations announced with big fanfare a number of years ago that there was a consensus approach to attribution. And so I was surprised to see that there was so much continued variation on the attribution. They said that they had voluntarily come up with a consensus approach. Did that come up at all in your interviews with the health plans?
So that didn't come up in our interviews with health plans, but I think it's important to remember that even if payers and providers come together and say, we agree on this set of methods to assign patients to providers, the contracting experience is one-on-one, and the different leverage that each player has on each side is different, and it might lead to variation in ways that people didn't anticipate when they said that we would kind of stick to this kind of shell of ways of assigning patients to providers.
Dr. Sun?
Did you look at the length of the contract that the payer has with their employers? I'm wondering if just like a length of contract. So like GIC, for example, their contracts are 3 years with 2 one-year extensions. I don't know whether that helps or hinders in terms of the people moving. I'm trying to understand like the behavior that's going on here. It's either
Right.
individuals moving from their employers, or is the employers changing their plans?
That's
when I was a CEO, I actually 4 years in a row changed my plan every year because of the extraordinary cost escalators. So I felt like I had to go out to bid in order to keep the premiums low for my employees. But I'm just wondering if that's a factor. It's a poor question because there's no answer to it. It's just a question mark. Whether length of contracts is a help or a hinder in these.
Well, we looked at persistency between fully insured and self-funded plans, and we saw that persistency was a lot higher in fully insured plans, which tend to have smaller employer groups who tend to need to switch more often between plans. So that kind of spoke to that, but we didn't look directly at the payer-employer contracts.
The churn rate is surprisingly high, and digging deeper and understanding why it's there might be worthwhile. Other questions?
Wasn't a bad question.
Thank you very much for a really clear presentation.
Thank you both. David?
Great. Good morning, everyone. And we're going to continue on this theme of behavioral health care and strengthening both behavioral health care and primary care with our next presentation leading into our first witness panel this morning. Before I call up, or you guys can come up. That's fine. Before I quickly introduce our guest speakers who we're so pleased to have with us, I do want to continue to recognize a few people who are in the audience and watching online. There is senior leadership policy staff from the Senate President of Maine, who's here with us and traveled to Boston to attend these 2 days. We also have senior staff from Senator Warren's office and Senator Keating's or Representative Keating's office, who was here with us yesterday, as well as elected staff and elected officials from Connecticut, New Hampshire, and California, all watching. So thank you for being with us. On that theme of learning from other states, we are so pleased to have Marie Ganem here with us today, and Chris Kohler for our next presentation. Their bios are in the program book, so I won't belabor them, but Chris is the president of the Milbank Foundation, and Milbank has done incredible work across a number of different topical areas, but has now taken on a big focus area on investing in and strengthening the primary care base of our healthcare systems, and is providing a lot of great guidance and evidence as many states are considering policies, including Massachusetts, on this topic. And we're also pleased to have Marie Ganem, who is the Health Insurance Commissioner for Rhode Island, has been in that role for a number of years. And Rhode Island was really a national leader in thinking about putting state policies in place to try to increase the proportion of our healthcare dollar that's going to primary care. So we're very pleased to have you with us to share your lessons learned and your perspectives. I should note that Chris Kohler was also the Health Insurance Commissioner at Rhode Island before his current position, and so I think has a great understanding of what went into that policy, how it became to be, and what some of the lessons learned are. But with that, Chris, I'm going to turn it over to you first to provide a little bit of a broader landscape of this topic, and then Commissioner Ganem for the Rhode Island experience. Thank you.
Thank you, David. And thank you, members of the Commission, for the chance to speak with you, and also thank you to staff from the Health Policy Commission and supporting offices who do great work on this stuff. As David noted, he described the fund. He also described my role. Marie and I have done this before. I would just note that in moving from myself to Marie as Health Insurance Commissioner in Rhode Island went from quantity to quality. So, we got Marie up first. Is that?
Oh, sure.
Okay, let's do it. Thank you.
So you're going to get the deep dive first in Rhode Island, then you're going to get the state.
We always prefer to start with quality.
That's right.
Yes, I was originally going to say that was the long and the short of it, or the tall and the short of it, but now it's going the opposite direction. I also thought last night I sit in the same seat that Chris sat in and at the same desk. And of course, for me, it's a stand-up desk. So, but we are continuing some of the same activities. That's it. That's it for those jokes. So we just thought we'd start by kind of framing what the Office of the Health Insurance Commissioner does and is, and what our responsibilities and roles are. That really sets the foundation for the primary care spend topic that we're going to go into today. So first and foremost, and thank you, Madam Secretary, for raising this issue, and that is protecting the interests of consumers. And every insurance department across the country, including yours, which we work very closely with, and we're very appreciative of that relationship, we focus much of our attention on protecting the interests of consumers, and that legislative charge can be interpreted very broadly. And there are, we have regulatory authority that we interpret to come from that basic premise. Guarding the solvency of health insurers, again, that's a standard activity of health insurance commissioners all across the country. But encouraging policies and developments that improve the quality and efficiency of healthcare services, the delivery and the outcomes. That's something that is relatively unique. There are some other states who take this charge kind of seriously and under their wing, but we use it to provide statutory authority for regulations. And then lastly, viewing the healthcare system as a comprehensive entity. And this is where our behavioral health activities really have come from, and the source of how we've been able to exercise some interventions at that level. We're encouraging insurers toward policies that advance the welfare of the public through overall efficiencies, improved healthcare quality, and access. So with those statutory charges, you can just let your imaginations run as to what you would want to do if you were sitting in this seat. I'm going to give you the kind of the very, very high level. The agenda for today that I was going to walk through is just to talk about our primary care investment in our state, what the considerations were for policy design, which I really have to credit Chris for because he put the policy in place when he was there, how we're tracking the investment and what the accountability is, what our next steps are, what the integrated behavioral health model looks like in our state, and what's next for payment reform for moving this agenda forward. But I'm going to give you kind of the high-level takeaway right now, and that is that we have in Rhode Island consistently ranked highest or among the highest states for the number of primary care physicians relative to the population size. Simultaneously, we consistently rank in the bottom of the country, within the lowest 10. Maine and Delaware are down there with us consistently in terms of salaries for primary care providers. So it's either the ocean breeze, the fact that there's no commute time between home and work, or there are other things that we're doing that are helping to lead to satisfaction in their work. And surveys have been done that have shown that our docs tend to be satisfied, and particularly those that have gone through transformation into team-based care. They express the loudest level of satisfaction with their work. And pediatricians, for some reason, are very happy people, and they're very happy to be with us. So that again, we can't draw a direct correlation to the work we're doing, but we hope that we're impacting that kind of quadruple aim mission of joy and work for our providers. So primary care investment in Rhode Island in 2010, when Chris Kohler was the commissioner in Rhode Island, the Office of the Health Insurance Commissioner required commercial insurers to increase the percentage of their overall medical spending dedicated to primary care by 1% per year for 5 years. Now the stipulations were they couldn't increase overall medical spending. They couldn't reflect this increase in premiums. So we believe that some of it came from another stipulation, and that was that there is a cap in Rhode Island, regulatory cap, as part of our affordability standards that Chris put in place on hospital contracts. So annual contracting between our commercial payers and our hospitals are limited to a growth cap. And that's set right now at CPI plus 1%, which just coincidentally has been the same as our growth target overall. So the primary care spending requirement was one of several requirements in these affordability standards that OHIC created and that Chris took a beating for, but we're happy to be on the other side of that. Yes?
Could that be done either through prices or volume, or didn't matter as long as they spent more?
I mean the growth.
The primary care spend?
Primary care spend of 1%.
I have some slides on that.
Oh, good, sorry.
Thank you. And the answer is yes. I'm not advancing. There we go. No, backwards.
Just point it, I think, at the screen.
I'm pointing. I'm not. That's it. I guess I don't have slides on this.
We have.
I can go back. Oh, thank you. But I need one more. I need one. Thanks, Chris.
Just say when.
Okay, thank you. So this chart just shows what the rationale was for the primary care investment in our state and what we hoped to accomplish. And I'm sure it's the same as what you're proposing in Massachusetts to do. And first is to correct an underinvestment in Rhode Island compared to high-performing systems. Second, it was a policy lever to drive transformation. And that is really key for us. Just putting money into reimbursement, we knew would not change the system, and particularly would not lead to better outcomes for patients, which of course is the bottom line. And we saw the opportunity to improve system performance on cost, quality, and access. The evidence does show that the increased primary care availability and access and utilization will in fact have a positive outcome on cost, quality, and access. Thank you, Chris. So just from our experience, what we would consider if we were to design this again is the definition of what constitutes the spending on primary care. What do you spend it on in addition to reimbursement? What are the factors that you're looking to encourage in your state? What are the needs, particularly in your state? In our state, when this went into effect, we had many, many, many practices that were not on electronic medical records. So clearly one of the investments that we were looking for the providers, we actually required the providers to make, was in electronic medical records, not only investing in the infrastructure, but also in facilitating their utilization. And we had a multi-payer effort to get that done. Also, measuring your baseline is critical, and also how does that compare to whatever the benchmarks are that you're trying to achieve, and we'll show you how that was done, again, under Chris's leadership. And then what are the outcomes you're striving for in your particular state? If, in fact, one of your outcomes is integrated behavioral health, as we've heard from previous speakers that say so eloquently, then certainly building that into your system right from the start would be great. And once you decide to increase investments, what specific investments should you be encouraging? Thank you. So Rhode Island used the mandatory investment in primary care as a catalyst for practice transformation and payment reform. We've probably done better on the first than on the second, but we're focusing on both pretty intently right now. The practice transformation has been conducted primarily through a multi-payer convening. It has actually morphed into its own private nonprofit organization. And on the board of directors are all of the insurers represented, a number of individuals from the primary care community. They're very much actively engaged in the process. And it is a convened organization by my office and the Medicaid director, and that helps get through some of the antitrust issues that could potentially come up around the table. But the team of that organization, which originally was more of a collaborative, I think when Chris formed it, the team works to facilitate practice transformation. So they're on the ground in primary care practices, helping them build the teams, helping them determine how to use what specifically they need to ask for from the payers and how to use those resources. They're training the nurse care managers, they're training around the team approach, they're training on behavioral health screening in the practices, and they're really there to support in very many ways the practices moving on to become primary care medical homes and then to get that recognition. So we any support, financial support that is provided to that organization by the payers is considered part of their primary care spend. Any contributions they're making directly to practices to get recognized by NCQA as primary care medical homes is recognized as primary care spend. In addition to financing our health information exchange, which provides client-level information to the practices to improve their quality and outcomes. So this convened multi-payer project and that encouraged the investment in PCMHs was also put into statute. So in addition to our regulations from the office, there was also a piece of legislation. We have actually never really enforced the legislation because we've had voluntary commitment around that table for the insurers to do this. We have never once had to penalize, although there are provisions which we could, but we've not had to penalize any of our insurers. They report to us regularly what their medical spend is. There's a formula as to what goes into the numerator and the denominator, and they report that to us regularly. If they're off, then we ask them how they are going to make up the difference that next year. Very often, they are funding things like community health teams, which are supporting our primary care practices, particularly in identifying and addressing social determinants of health and behavioral health issues. They are investing heavily in ancillary providers in the different practices and a pilot integrated behavioral health program going on right now. So those are extra bonuses we're getting when we notice that a certain insurer might be off. So most of our investments have been through non-fee-for-service payments that like those that I just mentioned to you. So there are certainly have been some reimbursement increases to the providers directly, but most of the dollars you'll see on a later slide have specifically been encouraging this growth and development in the primary care offices.
And if I could be a historian there, at the beginning, it was actually stipulated by our advisory council that all the increases should be outside of fee-for-service. So it couldn't be in increases in CPT codes. It had to be in practice transformation resources, common good things.
Yeah, I think that was key. Thank you. So this was just a real quick slide, how we set the baseline. The last line on this chart, Neighborhood Health Plan of Rhode Island, is there because I think Chris was the former president and CEO of Neighborhood Health Plan, and he wanted to show how well they were doing at the time. But the rest, as you can see, are also recognized as high-performing systems, and Rhode Island was not looking as good at that point in time. Thank you. So I mentioned how we track and hold them accountable. And this is some of the results. So the baseline was set actually in 2010, but this was the tracking from 2008 that was being done. Our largest payer actually had already been looking at primary care medical homes, and I think that put some of the wind in the sails to advance this process. They had also, I think in 2013, done an assessment and evaluation of a return on investment study on their investments in primary care medical homes and found a 2.5 return on their investment for every dollar they spent. So that has also helped us to continue the momentum behind this. So you can see we asked for 1% increase each year to get to about a 10.7 rate. Now we're looking at new regulations, and we're going to be looking at about 11.7 and keeping it our level there. Our largest insurer exceeds that level. Some of our smaller insurers or smaller market players are actually a little bit below that. So we set it at an attainable goal going forward, but you can see we've seen a dramatic increase both in terms of dollars invested and in terms of percentage. This is just the dollars, and in case people were interested in looking at it in that way to figure out the math. Our increase has been roughly about 50%, but I hate to do quick math in front of David Cutler, so I won't do that. So I'm going to put to another slide quick. So we're this slide just shows each individual insurer and what their track record has been, what their history has been. Neighborhood Health Plan has recently become a commercial player since the Affordable Care Act, so they're the lower gray line there. And Tufts is really working at increasing their market share in Rhode Island, so they have a little bit more volatility in terms of both the numerator and denominator here. But the other two carriers, you can see that they're both trending in exactly the same direction. And you can see that their non-fee-for-service payments in primary care are now exceeding their fee-for-service payments in primary care. So again, difficult to draw direct correlations, but this year Rhode Island was ranked as the most improved state. You know, I'm not sure that's like being number one, being most improved. But we should be proud that we got there. Our overall ranking was 7, which is reasonable and very good. But the Commonwealth Fund assesses and ranks each state on 47 measures of healthcare access, quality, efficiency, health outcomes, and disparities. This year we were ranked as the #1 most improved in the country because we leapt forward. And part of what I see the primary care investment helping us with is clearly access and affordability. And you can see we jumped up 10 levels there. Certainly prevention and treatment, and we jumped up 15. We should be having a greater impact on avoidable hospital use, but the cost factor could be trending in here too. Healthy lives moved up 14. So and also addressing disparities, which is another attribute of a high-functioning system with heavy contribution in primary care. So I do believe that our emphasis on primary care has helped to move these numbers forward, and I know our governor is very happy and very proud that we are making this kind of having this kind of momentum. She has set as a priority for us, Governor Raimondo, since she was elected, a focus on behavioral health. And within some of these rankings, of course, is access to behavioral health services. And two of the places that we actually scored very well was access to behavioral health services, and for both adults and children, and reducing the unmet need, which was very high in our state and still is. We still have a long way to go. We still have our opioid epidemic is still a real challenge, as in other states. But we hope that the concerted effort to invest in primary care is helping us broadly. Thank
So
you.
may I just,
Yes, Secretary.
it's a terrific presentation. I just want to be clear, so your investments are to the commercial products only, does not include your state, does it include your state employee health insurance and or Medicaid?
So thank you, that's a great question. Yes, our multi-payer effort does include the state employees plan to the extent we can convince them to do these things, yes. But Medicaid is very much aligned with us in this effort. And our commercial payers, some of them, and I'm not going to mention specifically whom, but some of them actually do the same in their self-insured. So there may be TPAs for self-insured plans, and they actually are doing the same kinds of activities in the self-insured market that they're doing in the fully insured market.
Thank you.
But self-insured's a problem, speaking as a recovering regulator. And so you do this hard work in the commercial market, and you hope that the rising tide lifts the boats. But the self-insured have clearly benefited from the improvements that Marie cites without necessarily paying commensurate costs.
Yeah, yes.
So this is fascinating. So can I understand, the idea was that in terms of the financing of it, that it would come out of the hospital budget of the commercial insurers. And
Or
so-
other cost containment.
Or other cost containment. And I guess the question is,
He
like,
should answer that.
how have you found that to work out? Like, do the insurers complain, oh my gosh, we have to spend more on this, but you're not letting
Right.
us raise
Chris
our
is-
rates, and
Chris-
this is
yeah.
problematic? Or do they say, oh, actually, we've seen these offsets on the acute care end, so this makes it be easier
no.
for us to do?
Oh, no. No,
What happens on the back end?
The dynamic is that, as Marie cited, there was a recognition of the value of primary care,
Yeah.
and that it was undervalued in the market, that there was a market failure. And so, again, acting as historian, when we have an advisory council that recommended this, saw the data and said it, and we turned to the insurers and said, you're going to have to increase your primary care spend without increasing your rates, and it's not going to be able to go into, it's going to have to go in non-fee-for-service. And they said, what do we do when we talk to the specialists? And we said, point to the health insurance commissioner. And that's what they did. And so even the primary care spend was enacted before the hospital rate increase caps. So the transfer happened before that. The rate caps were a secondary evolution. And we did not see a flood of specialists heading north. It might have been the ocean breezes or something like that. But if they had to live with 3% as opposed to 5% increases so they could fund, they did.
When you said it can't go into fee-for-service, what exactly did you mean? You can't raise prices?
It meant that our advisory council was sufficiently influenced by the importance of alternate payment mechanisms and the need for these common good investments, that their directions to the health insurers were this increase, when you move from 6% up, the money had to flow to primary care practices in non-fee-for-service means. You couldn't just raise the CPT.
So
that
what,
mean
what
that-
does that mean?
Yeah.
So
I don't-
let's
I
say
don't
I'm
get
a
it.
primary care doc at Coastal Medical, and I've got, 500 Blue Cross patients and 200 United and 100 Tufts, and so I got that's 1,000 patients, non-Medicaid, non-Medicare,
Right.
commercial patients, and in 2008, it's all entirely fee-for-service.
Yep.
And this process has moved into non-fee-for-service. Does that mean I get a prepayment each month? And
We don't know, we didn't know the specifics, but it meant that when Coastal sat and talked to the health plans, they said, we know you have to give us more money, and it can't be in fee-for-service, so let's talk. And it
and
could
has that
be-
been manifest in primary care caps?
It's been, what Coastal tells us, and you can handle this question, I'm talking too much. Okay.
So there are quality incentive performance-based payments that are going to the practices. There are payments going to the practices to support the teams, the interdisciplinary staff. There are payments going to support opening longer hours so that our primary care practices can open at the hours that are more accommodating to patients.
So the incentives are not fee-for-service, they're quality-based incentives. But is the basic contract still fee-for-service?
That varies dramatically. For instance, Coastal probably has very little fee-for-service in their contracting, but I think it varies. Chris?
And Coastal in particular, at the same time, was embarking a little bit later on becoming a Medicare ACO. And so they viewed the primary care spend requirement as capital financing, just like what were getting from CMMI. So they used it as part of their capital financing to build their accountable care capacities.
But you raise a very valuable point, isn't that Coastal is a huge, is our major physician-based ACO in the state, but we have a lot of ones and twos and threes practices across the state. And so when I took this position, Chris warned me about a lot of the landmines, but he didn't warn me about these. So the first was that every specialty society in the state wanted to see me. And that was fun.
I bet I know what they said.
Yeah. And they thought I was a good sport. And secondly, the family practices, which are really the smaller practices, some of them, not that we have really isolated areas in our state and rural areas, but some of them are in the outskirts of the state. Not the boutique practices, which decide not to take insurance and do their own thing, but these are real, real family practitioners who practice and really care very well for their patients, and probably adhere to most of the principles of a primary care medical home. But they don't have the resources or the infrastructure. They can't support a full-time nurse care manager. They can't support electronic medical records or to keep them actively engaged. And much of what the expectation is to become a transformed practice is just not something that they're either willing or able to comply with. So that has created a bit of a struggle in our state. We originally, the affordability standards and the act that passed about primary care medical homes had a target of 70% of our practices in the state being transformed into these quality approved patient-centered medical homes. And we did meet that. We're close to that, but we almost can't go further. There is another goal that put us out a couple of years to hit 80%. I'm not certain we're going to get there because these practices just either cannot or will not. And again, it doesn't mean that they're not providing quality care, but unfortunately, they are being left behind. So some of these incentives, the performance-based payments, are stopping, and they're not going to be benefiting, unfortunately, from getting more referrals. At least one of our major insurers is now changing their copayment structure to incentivize patients to go to the primary care medical homes where they see lower cost, better quality. So that is a dynamic that we see.
Can I ask just one question? What was the process you used to come up with the target?
The 70%?
Yeah.
Oh, I don't know, Chris, what was it?
Do you mean the 70% or the target for improvement or the overall spend
The
target?
target of improvement.
Oh,
The 1%.
1%, sorry, 1%.
The 1%.
The
either one of us
1%
can
per
do
year.
that.
For 5 years.
We took it was a little bit of a thumb to the wind around looking at what fully integrated delivery systems like a Kaiser gets, as near as we could tell, and we were looking at other countries.
And we said 1 point a year for 5 years, and let's see where that gets us. And it was subsequent to that, when we got to about 10 or 11, that the then commissioner at the time said, I think we're at about the right point. And so they weren't going to increase it beyond that. But we knew that 5% was too low. We knew that 15% was too big. So, and there was a sense that the marginal dollar is better spent in primary care than it is in some of the other places that insurers can spend it.
Just being cognizant of the time,
Yeah.
why don't we
Yes.
continue with the
you.
presentation? And if we could just hold the questions.
Thank you, certainly. So we're at next steps. So we prioritized the integrated of behavioral health care in recent years into primary care as a cost-effective way of increasing access to behavioral health services. So we too have the same findings that I've heard from previous speakers that you have here in the Commonwealth, and that is that we have a shortage of providers and also a shortage of providers who are in-network who accept insurance coverage. So by expanding the capacity in integrated behavioral health practices in primary care medical homes, particularly by bringing in either social work or psychology level individuals to work with their patients, we are extending the access to those services. Our pediatric practices are having very good results with another model, and I think you also have this in the Commonwealth here, and that is where they can call our local child psychiatric hospital and get a clinician on the phone, and then the primary care doc can basically then prescribe, then make the recommendations right on the spot with the family and with it. So we're doing whatever we can to increase the integration of behavioral health services into those primary care practices. The 2019 analysis of our collaborative, basically the multi-payer effort utilizing community health teams shows that we have reduced patient health risk, depression, and anxiety. And so these community health teams are partnering with our primary care settings to have a real impact in behavioral health. Among other successes, the Integrated Behavioral Health Program has shown reduced emergency department visits. And so as a result, we're taking those results, they're taking a pilot program, and we will be in our next set of recommendations for proposed regulations, which are coming out soon. We're hoping to remove administrative barriers to integrated behavioral health, such as 2 co-payments for same-day visits, such as billing on a primary care doc being able to bill under a specialty code, et cetera. So we're trying to address those barriers, and we're also promoting payment models that'll enable us to sustain the integrated part of the behavioral health. Okay. So we are, as I mentioned, encouraging the adoption of alternative payment models for primary care. This has been slow to catch on in our state, but again, our new regulations will be moving us hopefully closer in that direction. We're looking at capitation. We're trying to encourage transformation in the delivery of primary care to move from fee-for-service reimbursement. We have aligned measure sets, and basically we looked across our different insurers who were contracting with ACOs. We have other requirements about ACO utilization, and we found that they were requiring our providers to respond to quality and performance metrics that were diverse and actually administratively burdensome for the providers. So there's been a lot of work done, and in 2020, we will have just 8 core measures and 14 menus. What that means is that the insurers will be required in our regulations to choose to use those 8 core and to choose from that 14 measure, and that's it. And they're all defined the same way, so the providers are not overwhelmed with various reporting requirements. And we update these annually. And this is just where to get us and where to find more information about what we do. Thank you.
So, thank you. I will, my role here is to provide a little bit of national context around the primary care spend, help the commission understand what other states are doing, although you heard from the exemplar in Rhode Island. If I may, this may come up later, but I do want to address Professor Cutler's comment earlier about recommendations. Something that Commissioner Ganem didn't bring up is this is specifically focused on commercial insurers, and it's done in the context of regulation. So this is the same person, an office that is reviewing the rates for large, small, and individual group. So it creates a dynamic around coming to alignment on these sorts of things. It's important. But anyway, what's going on in the other states? Just to go back, when we talk about primary care, this is what we're talking about, whether it's defined by Professor Starfield or the Patient-Centered Primary Care Collaborative, to just sort of orient us as to what is primary care. Secretary Sutters, this is as close as I can get to consumers, but this is the why primary care. It makes people healthier, and it makes the population more equitable. This is kind of what we're about. And it's a little bit cumbersome. We can't come up with a better phrase, but we would posit that what we're targeting here is a primary care-oriented healthcare system. That's what we're striving to do. The evidence is gathering that if you want to promote a primary care-oriented delivery system, a way to do it is to focus on primary care spend. And so, my professional goal at the fund is to identify that there is a mustard slice identified for primary care that's separate from pharmacy or specialty care or hospital or anything else. First, we got to have it being a differentiated slice, and then we got to grow it. And so that's our attempt to do that. Primary care
So
spend
where's
is,
behavioral health embedded in everything else?
yeah, right. And this is we'll get to the definition issue. No, that's right. This is what's in what do you define as primary care?
Right.
But right in this slide, it is not in the mustard slice here. So we've got correlation, not causality. Sorry, the circle is a little bit off center on this one. But as primary care spend increases in the U.S., it looks like ED visits decreases. Massachusetts is a little bit to the left. I didn't mean to circle Tennessee. I meant to go a little bit up and to the left to Massachusetts. I got it right there. As primary care spend increases, hospitalizations go down as well. So we've got some correlation. Can't call it causality, but the evidence is pretty strong. The premise behind, and I think I know this is in the context of the governor's proposal, we would say the evidence supports that you cannot expect that just because you advance APMs that they're going to wake up and give primary care spend its just desserts. The economics, primary care oriented ACOs are doing better, but there's a lot of non-primary care ACOs. I don't think we can wait to move for all those ACOs to wake up and smell the coffee and hire a bunch of primary care docs because healthcare doesn't follow the rules in the markets, and you got to get to the politics as well as the economics of it. And that's really why states are focusing on the primary care spending. And I think it's consistent with a market oversight. Too often we look at this as either we have to let the free market go or we have to have heavy-duty regulation. I think what's needed is market oversight of the kind that Commissioner Ganem's talking about. So these are the states that are looking at primary care spend right now. They come in sort of 4 levels, simply in order, and when I say looking, I mean they've got some sort of statutory activity. It's either somebody go report, somebody measure and study with a commission, or you actually increase and maintain. To date, Oregon and Rhode Island are the states that have taken that last step where they've actually dictated an increase of the kind that is in the governor's proposal here. I would note that what a number of these states have in common is they're not just, part of the reason why they're working on primary care spend is what Commissioner Ganem cited, which is that they've been convened to look at primary care. A number of them have used the Medicare multi-payer payment model, MAPCP, and Comprehensive Primary Care Initiative as kind of an organizing principle. It doesn't necessarily mean that Medicare's got the payment model right, but if Medicare has stepped in and said, we want to get payers together to focus on primary care, you're creating a table where these issues get discussed, like what's in the numerator and things like that. So that's certainly been the case in Oregon. It's been the case in Colorado. It was the impetus in Rhode Island a long time ago. Vermont had it going before Medicare stepped up. I want to note particular activities around reporting and studying in New England. There's been nice collaboration at the staff level around this. A lot of this with backbone supports provided by the staff at the Health Policy Commission. So David, thank you for your staff support of this work to just kind of create a conversation across borders about what's going on. We have regional economies. A regional focus on this makes a lot of sense. Plus it builds some collegiality around the issues. So what's the biggest lesson around this? The states that are working on this have an ongoing public discussion around primary care spend. They don't just report and have a report that's put out every once in a while. They have a table where people are gathered saying what's working, what's not, should behavioral health be in it, should it not. Oregon has been very instructive in this. They have work specifically focused on primary care, and Commissioner Gamm described the work in Rhode Island. Because what you're doing is creating a public discussion that prioritizes primary care, that keeps the goal on a primary care-oriented delivery system, and one, frankly, that other parts of the delivery system that have been beneficiaries are, the agenda is not being set by them. What's in? This is the question that Secretary Sutter's asked. We at the fund have put out sort of a measurement template that says you think about the specialties, how you define it in terms of specialties, and how you define it in service codes. We find that states are not waiting for a national definition. Different states are taking different efforts. For your purposes, it's important to note that Oregon's definition includes psychiatric services, adult and kids. It doesn't appear that it includes counseling, so they don't get social workers and psychologists, but different states are having different definitions. We encourage that. We don't think you can wait for a national definition on this. What are some of the other lessons? A lot of discussion about the perfect versus the good. Are we encouraging A1 transform primary care or with a primary care spend measure, or are we encouraging primary care in general? We would advocate for the good rather than the perfect, and get the dollars into primary care however you define it, and then we can work on improving it in the way that Commissioner Gamm talked about. What's the accountable entity? Is it the state? Is it the health plan? Is it something beneath that? Your work around total costs of care measurement actually set the path for that because you've already taken on some of these issues. And then what's an adequate level? The question that was asked here. We've been able to document that, not surprisingly, it depends on the population. You're going to have a lot higher primary care spend population in moms and kids. When you do this for Medicare, the number's a lot lower. So you need to think about payer type on this, just like you have to do when you look at the total expenses as well. But don't let that be the enemy or reason to stop. You got to measure, and then you can set the level. And then, is this a target or a standard? This is, again, part of what is teed up in the governor's proposed legislation. More lessons. We are learning how to account for non-fee-for-service spending, such as these categories. That bedevils us, quite frankly, because it's hard to find those dollars as they flow through in bonus payments and capitated payments, things like that. Oregon's done some good work on that. Where do the increases go and how directive to be? Rhode Island took a pretty loose approach, just said, don't put it in fee-for-service, we'll learn as we go. In some cases, some other states want to be more directive, so you have to think about that. And what's the relationship to broader delivery system reform? Commissioner Gamm described some of these. These are technical questions, like how to account for fee-for-service, non-fee-for-service, and bonus payments, but they're policy questions as well. That's why you need a table where you continue to talk about this and refine it over time. And then lastly, I think you folks, if anyone does, you do, you recognize that primary care spend is not the silver bullet. And Commissioner Gamm has to spend a lot of time on that. It's necessary but not sufficient. These are some of the other things that if we want a high-performing delivery system that meets the needs of our whole population, these are the other parts to focus on. So thanks for letting me race through that. Commissioner Gamm and I welcome any questions.
A round of applause for our presenters. Questions, Don?
It's just great. How do you read the evidence, the scientific evidence, that the primary care medical home actually produces better results?
You want to do that or not?
So I can just start and let you know that it was our Blue Cross Blue Shield of Rhode Island that did the first study that showed the return on investment. And I like to refer to that often because it's kind of on the ground in Rhode Island. But then the other studies we think are showing some clear evidence, and Chris has got all those.
Yeah, and I would say, I'm not sure that we've got the exact ingredients of a patient-centered medical home, but what I think this evidence shows is that, one, we're not spending enough money on primary care. You got to get the money in, and then you figure out exactly what for, and the importance of the local conversation. You know, Commissioner Ganem describes is an ongoing discussion in Rhode Island about how to have a primary care-oriented system. We're not going to get it right the first time, but we've got to create this table that keeps working on the issue. You know, this doesn't take on the issue of provider prices, which is, you know, that's got to be done in a separate place, but we need a primary care-oriented focus.
Tim?
Yeah, I was just wondering, I think you mentioned earlier too that the price cap came in after making these targets. I'm just wondering, do you have a sense of how important are the price caps in managing the investments that need to be made based upon the 1% goal while managing the overall cost growth in the state?
So Health Affairs published a study that was done by some Harvard Medical School scientists along with someone from Stanford that actually tried to evaluate whether it was our primary care spend, our hospital cap, our ACO investments, and really what in our affordability standards in Rhode Island had an impact, if in fact any impact, on our costs, and showed that our affordability standards did in fact curb our growth in healthcare costs to the tune of about 8%. So the control group versus our actual expenditures. But when they dug down deeper, they attributed pretty much all of it to our hospital rate cap. So clearly having that growth cap in hospitals was the lever that has made anything else possible.
David?
Chris, can I take you back to the chart showing the New England states? So the most comparable set of numbers here seem to be between Massachusetts and Rhode Island because they're all commercial payers.
That's
And
correct.
so Rhode Island is 74% above Massachusetts, so the 11.5 over the 6.6. So I'd been thinking since the governor's proposal about how to gauge the 30% number, and I think if I understand that right, the 30% would be...
Is this apples to apples?
As a dear, you got to put a pretty wide confidence interval around it,
Right.
but it's commercial payers only. So Professor
But
Cutler's,
doesn't the Rhode Island numbers include non-claims-based?
yes,
Right, and the Massachusetts doesn't.
no, it does not. So to the extent there's a big non-claim space, you have to, and
Yeah. Is there a way to say, like, where Massachusetts is relative to other states on an apples-to-apples basis?
it'd be very hard. I mean, I would actually encourage the staff level conversations. If you asked, they could sit down and try to do that. I don't mean to create work for David and his staff, but
I think maybe creating work for Ray, so I'm not, I'm not that.
Actually, Ray has the data.
Right,
on
we
payers.
HBC and CHIA have been looking at, actually,
Right.
David, I think you can speak to it a bit better, but we've been looking at it a bit. We have an initial, preliminary sense, but also I thought Milbank had also done some national work looking at primary care spending levels using the broad and narrow definitions nationally. So we do have some sense, but it's extremely preliminary of what, the numbers are looking like.
yeah, you could get, we don't have Rhode Island on here because this was done off of MAPS information, but this would be another apples to
Right.
apples.
That would
where
be-
Rhode Island would be way out beyond the 8%.
Right.
We can make sure we circulate that, but there are tables that we've done kind of internally and then also ones we've seen nationally of how it looks. But this is something CHIA is going to be including primary care and behavioral health spending in the data spec that we roll out next year to measure this year, 2019. So we'll have a much better view of this next year and then increasing, but that'll be the first time we collect the data. It'll be preliminary data, so we'll have an increasingly refined sense of primary care and behavioral health spending in Massachusetts starting a year from now, and then it should be fully mature a year after that.
But to answer Dr. Cutler's question, the 30% did not come from just looking up at the sky and coming up with a number. It actually was the result of some conversations with CHIA, HPC, my staff, and some others around. And
not
with our
nearly as
colleagues.
outrageous as the 100% that we came up with in Rhode Island. So.
Yeah.
Chris?
Yeah, state-based initiatives, starting small, bubbling up. Congratulations on what you've accomplished. Is there a forum, if there was a single forum where the state insurance commissioners or some other entities, maybe Milbank convenes, but if there was one forum that you could recommend to the HPC staff for local experiments so that this table gets bigger and louder, what would it be?
first?
I want to, there is no one forum. I think the insurance commissioners are part of it, and Commissioner Gamm can speak to that. There are a number of state-based technical assistance groups, including Millbank Memorial Fund, the National Academy for State Health Policy, that are working on these. And I would say this if they weren't here, but the staff from CHIA and HPC are plugged into those right now. They contribute. The network is small, and these guys know who one another are to talk about this stuff. So.
Yeah, and I would just credit Millbank for being a facilitator and a supporter of a lot of these conversations. There's a New England States consortium of systems organizations.
Very good. Yeah,
I read it off the slide. NESCO. But that is a New England state group, and we've had conversations both on this issue of measuring primary care, learning from other states of how to do this. It is complicated, and there are decision points that go into it, but also things like our market oversight and consolidations across state lines, where we're seeing an increasingly regionalized health system, and of course a regional economy. So there's a great forum for this, but it's a great idea.
So our next panel includes some innovation in primary care. Do those innovators, or previously, we've had Rashika and Iora here, do those entities get a chance at pitching what they're doing differently?
I think it's
at these forums.
It's a great suggestion. I think some of these forums tend to be a little bit of the government people, but I think there's a great opportunity to bring in the private sector and some of those innovations to the conversation.
Yeah, I would encourage that.
Yeah.
There's also the National Association of Insurance Commissioners, as you mentioned. I'm helping to chair a committee, a work group on healthcare innovation. And so those states that are interested in innovative approaches, mostly around cost, have been sharing those ideals and those ideas. So your Department of Insurance has also been participating. And we bring folks in to present what they're doing. Thanks.
I mean, this may be blindingly obvious, but the things to learn about are both how to change the flow of money, which is what you're talking about, but that won't do a thing unless the care is actually redesigned. And so the learning processes we're talking about that the state will have to support are going to be about the way the care is done, not just the way the money flows, right? That's what and Chris, your theory here is if you change the money first, then you can have the good discussion about the care. Is that your thing?
Oregon's been doing the same thing.
Yep.
Oregon used the primary care spend money. They were very good with using federal money to create an Office of Primary Care Transformation. But yeah, that's the theory. You try to pay attention to Medicare because they are the biggest payer. And so if you can dovetail with what they're doing, that's why a lot of these states have jumped onto CPC.
It's just not automatic. If we got all the money in the world to primary care, it's not necessarily the case that the outcomes for patients would change, not unless the delivery.
And it also builds on the work that I think the commission has done around the primary care medical home. So there's a base.
Very good.
Thank you very much.
Thank
Really
you.
appreciate it. Excellent. Oh, we are going to take a 10-minute break, and we'll reconvene at 11:10.
Thank you. Oh, great. Yeah, it really was. Excellent. It was great.
Very good. I think what's acceptable. been sworn in, and I'm going to ask them to briefly go down and introduce themselves and their key point that they would like to make in this presentation, then we'll get into questioning. Richard?
Vice Chair, just really quickly, just have 2 opening slides for
sorry.
this panel. No problem. So quickly, just to set the stage here, wanted to share 2 slides. So this first slide, there was a long conversation at this last panel around the proportion of the healthcare dollar spent on primary care. And so, Professor Cutler, to your question, what we're showing here is results from a study that was done by the Patient-Centered Primary Care Collaborative, trying to do this very thing in terms of an apples-to-apples comparison. I would note this does not include behavioral health care in these estimates, and I think, as was stated before, Massachusetts may take a different approach in terms of calculating in exactly primary care spend. But this was one objective study that did try to create an apples-to-apples comparison. And what we saw in this study was that across all 3 major categories, Massachusetts was below national averages in terms of the percentage of dollars spent on primary care. This was a topic that we also asked about in our pre-file testimony questions to our 40 health plans and providers around what recommended strategies, what are their recommended strategies for supporting primary and behavioral health care and investments in those areas. On the left-hand side, you can see some of the identified strategies for primary care, including more investment in primary care, eliminating scope of practice restrictions, encouraging greater collaboration between PCPs and other members of the care team, and using different types of healthcare professionals like community health workers and care navigators. On the behavioral healthcare side, strategies identified included co-location of behavioral health and primary care, a call for increases specifically in areas of unmet need, such as outpatient behavioral health care, emergency behavioral health care, and the promise of telebehavioral health care. And again, an emphasis on multidisciplinary teams working together with a strong database and coordinating care for these complex patients. So this was some of the major themes that came out of the cost trends hearings pre-file testimony. And with that, we can turn right to the panel. And so I'll let you go first, Mr. Lynch.
Great, thank you. Good morning, thank you. I'm Richard Lynch, Chief Operating Officer for Blue Cross Blue Shield of Massachusetts. Blue Cross is leading health plan here in Massachusetts with just under 3 million members and one of the leaders in health plans nationally for overall patient care experience and quality. I came to Blue Cross about a year ago after 30 years of experience in healthcare in a variety of other settings. And I'm really happy to be here today, particularly happy to be on this panel because we're proud of the work we've done at Blue Cross, innovating in alternative payment models that really influence and place a lot of importance on primary care and behavioral health care. Earlier this year, a study was published in the New England Journal of Medicine that showed our alternative quality care model helped to reduce the rate of increase in spending by about 12%, up to 12%, while improving patient care over the course of about 8 years. While we're proud of that, we recognize there's still a lot of work to be done here, both in primary care and in behavioral health care. I started my career in healthcare about 30 years ago as a nurse, and then as now, as Chief Operating Officer of a large insurance company, I've seen firsthand the importance of primary care and behavioral health care for driving quality and affordability in healthcare. So I'm happy to be here today, and I'm looking forward to the discussion. Thank you.
Great, thank you. Christina.
Hi, good morning. I'm Christina Severin, President and CEO of Community Care Cooperative, or C3. I'd like to thank Vice Chair Cohen, Secretary Sutters, Executive Director Seltz, and all of the commissioners for inviting me here today and have a dialogue on the criticality of a healthy primary care and behavioral health ecosystem. C3 is a nonprofit mass health ACO governed by federally qualified health centers. We founded the organization in 2016, and today our statewide business has 19 FQHCs at 126,000 members. We're currently the largest mass health ACO. Many of these FQHCs are national leaders in behavioral health integration, and all are PCMH accredited. Nothing is more important to us than strong, effective, and independent primary care. Over the last decade, independent primary care has become an endangered species because the financial equation has driven community-based providers to seek shelter within hospital systems. Currently, over 90% of the state's primary care is employed or contracted through a hospital system. The evidence shows that effective primary care leads to better outcomes and lower total costs for consumers, employers, and government. And while Massachusetts has led the nation in expanding healthcare coverage, a July report supported by the Milbank Memorial Fund found that we have been among the worst in our investments in primary care. Only 8 states spend less than Massachusetts on primary care. Given all of that, I could not be more enthusiastic about the governor's healthcare bill. The bill calls for payers and providers to increase annual investments in primary care and behavioral health by 30%, and importantly, requires this to happen within the state's current spending targets. Governor Baker's bill marks an important step forward for Massachusetts. Nationally, there is growing awareness that provider-led organizations are more effective at managing total cost of care. Analytic findings of Medicare ACO performance published last week by Avalar Health found that physician-led ACOs generated nearly 7 times more savings than ACOs led by hospitals. In closing, we're optimistic that we're at a tipping point in our understanding of what will create fundamental success in the quest to attain sustainable healthcare costs and improve health outcomes, and we're looking forward to working hard to effectively steward these needed changes.
Thank you, Christina. Dr. Norman.
Good morning. First, I'd just like to make 2 quick comments. One in reference to Dr. Berwick's comment about next steps and what might the commission be doing slightly differently or in addition to what great work you're already doing. I just want to say sign me up for that as a volunteer for that activist arm that moves agenda items that come up in these great meetings forward. And then second, go Rhode Island. My name is Nancy Norman, and I am currently the Medical Director of Integration at the Massachusetts Behavioral Health Partnership Beacon Health Options here in Boston. I'd like to thank the committee for your invitation to join this important discussion today. We can embrace meaningful, high-quality initiatives that will strengthen primary care and behavioral health. My career in primary care and public health has been committed to improving the health of those most challenged. For years, I've worked in city hospitals and community health centers that have been a part of my community, geographically as well as spiritually. It has always been important for me to be seen as a positive force within my community, committed to listening to the voices of all and working with people to effect meaningful change. For 8 years, I had the honor to serve with Mayor Menino and John Auerbach as Chief Medical Officer of the City of Boston, where we worked tirelessly to make a difference upstream, focusing on school-based health, HIV/AIDS, substance use disorders, and much more. As Medical Director of Integration at MBHP Beacon, I've had the opportunity to continue this work with new colleagues who are clinical experts with purpose. Beacon manages behavioral health care for a broad client base that includes employers, regional and specialty health plans, and federal, state, and local governments. Here in Massachusetts, Beacon currently covers about 1.4 million lives, with about 500,000 of those lives being managed by MBHP in MassHealth's PCC plan, or one of 4 of the state's new ACOs. So what does Medical Director of Integration mean exactly? In my role here at MBHP Beacon, I have been the physical and public health expert helping to design and implement integrated care management programs, phone consultation services, as you heard reference to by our colleagues in Rhode Island. I'll make a plug and say, not only do we also utilize MCPAP here in Massachusetts, but MCPAP was made in Massachusetts. We focus on safe, other consultation services focusing on safe prescribing, if prescribing is needed at all, for patients with chronic pain, substance use disorders, or both, and several other initiatives that aim to improve access to all services while improving quality and satisfaction. I look forward to how our discussion today can truly move the needle forward to a stronger, more holistically integrated system of care.
Thank you, Nancy. Dr. Greenberg.
Good morning, and thanks for inviting me to be a witness today. My name is Jeff Greenberg. I'm co-founder and chief operating officer of Firefly Health, where I'm also a practicing primary care physician. Firefly Health is a new startup primary care service that launched last year. We are aiming to build a better model of primary care for everyday people. We are not concierge. We work with insurance companies. We don't charge patients extra. I've been working very well with my friend Richard at Blue Cross. We have 3 pillars to how we deliver care. The first is supreme convenience. So we are a virtual first model. We think most primary care can be done virtually. We also have in-person options for people when they need to be seen, but much of our care is delivered via video visits or secure text messages. And we aim to have great access, response times under 30 minutes when patients reach out. The second pillar is ongoing behavioral support. So we don't think that current telehealth models, the sort of dial-up a doc model where you get a different clinician each time, are very effective. So we assume we become people's primary care providers. We take care of people over time. We manage wellness, chronic disease, as well as behavioral health, and we have an integrated behavioral health team. And the third pillar is navigation. By doing the first 2 pillars, by being convenient and by providing great relationship-based support, we hope to earn the right to help patients navigate the system in a more effective way and to select higher value providers. So again, we launched last year and we're enjoying it very much and building up the practice and the model. And I guess you asked for my key point. I guess one thing I would say, and one thing we're really pushing for is just really pushing the needle on payment reform. Fee-for-service just doesn't work for a model like ours. There will never be a point where there is a CPT code for text messaging with a patient, even if that can prevent a patient from needing a visit, an urgent care visit. So we are working with Richard and others on primary care cap models. And I would just emphasize that, we really need to go beyond the sort of ACO model, which still incentivizes billing and episode-based care. And as we know, care has moved beyond episodes. It's all about prevention, weight loss, chronic disease, wellness. And to do that doesn't require a lot of visits. It requires ongoing care. Thank you.
Jeffrey, thank you. Dr. Folkus.
Thank you. Hopefully this was not symbolically important that you put me this far away from my microphone.
Actually, the closer you can hold it, the better for the audience.
I'm trying. Thanks for inviting me back. I'm the CEO of the New England Quality Care Alliance. I've been in that position for about 3 years. Before that, I was the director of primary care at the Brigham for about 6 years, where I worked with Jeff and other great colleagues to create 3 new practices based on the patient-centered medical home model and move the other 11 practices towards that direction. Relevant previous, I won't take you through the whole checkered career, but I was at one point the director of preventive cardiology at the Cleveland Clinic with the emphasis on prevention, and the chief of primary care geriatrics and healthcare research at University Hospitals of Cleveland and Case Western Reserve. I also had an interesting 4 years as the CEO of a small rural hospital in northwestern Connecticut affiliated with the New York Presbyterian System, which gave me a glimpse into that segment of the healthcare landscape, if you will, that I had not otherwise appreciated because of my time in academic medicine. And finally, the PhD after my name is in clinical psychology. That's where I started, and so I have had a career-long interest in achieving a functional interdigitation, if you will, of primary care medicine and behavioral health. We're not there yet. A moment on NEQA, a non-mellifluous sounding acronym. NEQA is the physician organization of Tufts Medical Center. It's approximately 1,700 physicians, about 500 of which are primary care physicians. The remainder are specialists. Those doctors take care of about 500,000 patients. Interestingly, they've been in risk contracts for over 10 years. They're currently in 17 risk contracts that NEQA helps negotiate for them. So they've done very well in alternative payment models and value-based care. Interestingly, about half of those doctors are employed and half are independent, and 72% of them are in practices of 3 doctors or less. So those demographics are important when we talk about the necessary infrastructure for creating team-based care and functioning in population health and value-based areas. NEQA has done a great job of creating programs and services to help physicians make the transition, however belated, from volume to value, and we can talk about those programs. I guess the one point I would make, and this has been alluded to by several of the panelists and those great presentations we just heard, is that, if you'll pardon a homely medical metaphor, I think we know the diagnosis. I think we understand the etiology and the pathophysiology. I think we're aware of the looming prognosis, and where we're stuck is what the treatment should be. And that's really what we've been talking about. So I'm frustrated because when I was here 3 years ago, we were really talking about the same stuff, if you will. So to your point earlier, can we generate the political will, which Don, you mentioned in the editorial accompanying Will Schrank's article, to move beyond where we are now? So thank you.
Thanks, Joe. Before I turn it over to my colleagues for questions, I want to pick up on your frustration point. I've been working in behavioral health policy for way too long, and this issue of integration has been something that we've been talking about at least for 25 years, and I see it on the margins. Last year we had 2 presentations, Manny Lopes from East Boston, Ed Moore from Harrington Hospital, wonderful models, but what came out for me was how fragile they were and that they weren't truly integrated in a real system of care. If we could just quickly, what can we do to change that? What's the one thing we need to do to change that? Richard?
So I don't know if I can give you just one thing, but certainly supply of mental health, behavioral health practitioners would be a big piece of that, a reduction in the barrier. And what we're talking about, increasing spending in both primary care and behavioral health care, I think will be important.
Can I just ask a follow-up? You may defer this. What are the barriers to creating more supply?
It's a great question. So, I think there's a lot of factors that come into play there. Part of it is probably where we are in the evolution of behavioral health care. As we're reducing stigma, we're creating more parity in the way benefits work in behavioral health care. We're seeing demand going up at the same time, combined with a need to make the practice of behavioral health care more palatable for practitioners going forward. So it's reduction in friction. Some of the work that we've done at Blue Cross over the course of the last few years has been aimed at that, right? Reducing prior auth requirements for outpatient behavioral health visits and so forth. And we've seen a pretty big uptick in utilization as a result of that, which is, we think, a good thing.
So can I? Yeah. So do your networks credential LICSWs in an independent setting?
We don't yet, I think, credential in independent
Number
setting.
one behavioral health specialist providers in the United States are LICSWs.
Yeah, no, I think that's a great point.
Christina?
So I think I might forget your exact question, but I think I remember it generally and picking off of.
We'll give you another one.
What Commissioner Coy said is, it's the economics, right? I think I made this point several years ago when I was testifying here, which is the system behaves perfectly in the way that we've designed the system to behave. Why do people go to the emergency department? Well, lots of important reasons, like advertising emergency department wait times. I mean, where do you start, right? Why do we not have SAMHSA level 6 models of BHI at all reasonably sized primary care clinical settings? Because the economics haven't supported it. I think when I was listening to a story from a colleague at the Dimick Center the other day, and they have a very advanced BHI model, stellar. and it's telling me a story about a patient, and this individual comes in and he spends about 2.5 hours in clinic, and he has 7 different appointments, one exam room. Right, all of the specialists are coming in and out, including behavioral health specialties. So it's, you know, and they have figured out how to underwrite that, and the creative ways that health centers have figured out how to do this stuff. And it's been enormously economically successful for the healthcare ecosystem at large. Hasn't been that successful for health centers necessarily, you know, but I think things are changing and we're incredibly optimistic.
Nancy?
Yeah, I think my, if I had to choose one thing, it might be looking at it from a slightly different angle, and that wouldn't be to, and by doing that, I wouldn't want to be downplaying the importance of having a number of behavioral health providers who accept all forms of payment. But I would question the underutilization of the network of providers, especially within the primary care pool that we already have. So I would want to be backpedaling. I recall my own training as a medical student and a resident choosing primary care, and the amount of time spent on behavioral health, mental health related issues was minimal. So I would want to maybe back up and focus on not just training for MDs, but nurses and all who are involved within healthcare, and encourage more of a focus on behavioral health, mental health issues.
Jeff?
Yeah, so Firefly, we believe integrated behavioral health is core to our model. We use a variant of the impact model out of Seattle. LICSWs are the core of that. They do our behavioral health assessment, triage, and ongoing support. So to support that, what do we need? I mean, again, we need a payment model that supports that ideally isn't fee-for-service. Interestingly, as an aside, the patients of ours who get the biggest bills are the ones who see our therapist, our LICSW. It just seems the copays tend to be higher. But what we look for is a primary care cap model where we can just deliver that fully integrated care and not worrying about is it a visit or what kind of interaction is it or how many times they see a given member of our team. What scares me, so our goal is to manage most mental health within our team, and we find that most patients don't need to go see a psychiatrist, but what scares me is when someone does, it's really hard to find a psychiatrist, right? We're independent. When I was at the Brigham, we could always sort of twist someone's arm to let them into Brigham psychiatry. Now, you call up psychiatry practices and they either don't take insurance or they don't want our complex cases. And that scares me. So it's that lack of supply when people truly have a significant mental illness that goes beyond what should be managed in primary care is a real problem. And I'm not equipped to answer why the supply isn't there, but it seems like insurance will have to outbid private pay if we're going to get there. But that's I don't teach economics to David Cutler either. So.
How do you change the incentives? There aren't enough providers. Primary care physicians and behaviorists make about 55% of what specialists make. So they leave $3 to $5 million on the table over a course of a career. How do you provide settings and practice models that will allow people to practice and see patients the way they wanted to? How do you value primary care and behavioral health? At the Brigham, I'm sure Jeff heard this, residents who wanted to go into primary care were told by their attendings, you're too smart to go into primary care. Mm-hmm. That has to change. And finally, back to economics, again, we have to pay people, but we have to take a long-term view of what the ROI is. I was impressed, Secretary Sutters, with the quote attributed to you in the Globe, that this proposal is, yes, it's going to take a while if we change where we invest, but we know, back to Barbara Starfeld and others, that where the density of primary care physicians is higher, there is decreased mortality, decreased hospitalization, decreased 30-day rehospitalization, decreased ED use, and there is a long-term ROI there. It's just that no one in the present structure has been willing to take that stance.
Thanks. Let me open it up to Barbara.
Thank you to the panel. Your comments are really well taken. I'd like to reflect back again on not enough providers and point out, as a nurse and a former nurse practitioner, that scope of practice issues are some of the most brutally battled out issues that we have. Clayton Christensen suggests that nurse practitioners are a disruptive innovation to medicine. And indeed, in fact, it is. Other disciplines are disrupting nursing, and indeed they are. And so the question becomes, when we know, for example, that psychiatric nurse practitioners in many states have prescriptive authority, how do we develop that, and how do we support that when people who complete that process, or any process, come out available and ready to work, and there are no positions for them, in spite of the fact that we identify such a huge need? And so what do we do to incentivize all of our disciplines to relax a little bit and to agree to look at where are the outcomes, who can best meet those outcomes, and work together to both incentivize from reimbursement to education to student loans and to interdisciplinary models of education so that disciplines understand what each of them bring to the table and how best to utilize and tap into those resources to make the most powerful, comprehensive, one-stop shopping mechanism for primary care and behavioral health that we possibly can. So I offer that as a comment, and if anybody would like to reflect on that, I'd be happy to hear.
Happy to take a stab. So we wholeheartely agree with the skill of nurse practitioners. Our model is very nurse practitioner based. So in our model, we use 3 nurse practitioners or PAs, and so far we've hired only NPs for each one physician. And the goal is really, for the nurse practitioner to deliver most routine care and even complex care, and the physician to support them, really flipped from what typical practices are. We haven't used psychiatric nurse practitioners yet. I think that's something we're looking at, and as we expand, we probably will. Right now, we've been using LICSWs with a consulting psychiatrist. My only question, I guess, would be who supervises the psych NP if we don't have a psychiatrist on the team. And so working that out, I'm sure there's a solution to that, but that would be something we would be really interested in looking at.
In many states, advanced practice nurses can now practice fully and without supervision. Massachusetts is not one of those states, and we don't benefit from that more collegial but independent practice.
I completely agree with you, by the way. I had the privilege of serving on a panel from the American Hospital Association a number of years ago on nurse practitioners. And I must admit that I came in, despite what I like to think of as a liberal stance, with my physician biases. And I looked at the literature in terms of quality and outcomes for the diagnosis studied. And the outcomes were just as good from that group of practitioners. So I agree with you, and there's back to political will, we have to overcome some of those biases. The team-based care model only works when there are colleagues, sorry to be corny, where everyone can practice at the top of their license. And there's a lot that can be cared for. In my fantasy practice, there would be a pharmacist, social workers, psychiatrists, nurse practitioners, geriatricians, and everyone. And by the way, that would obviate the need for being scared of telehealth and other disruptors, because the right patients could be cared for telephonically or virtually. So I'm with you.
Thank you.
I would agree with that concept of team-based care. I would also expand it to not only agree with your comments about maximizing scope of practice and team-based care, but that also involves non-licensed clinicians, right? Like community health workers and recovery coaches and peer support specialists are all really critical in a high-performing team.
Yep, agree.
I'll just add our support, very much supportive of the notion of clinicians practicing at the top of their license, and we need to move in that direction quickly so that we can get access to the access that would come along with nurse practitioners and others practicing more at the top of their license.
Thank you.
Don, you had a question? Yeah, thank you. So Jeff, I'd like to focus on you for a minute. So the Firefly model, convenience with a lot of virtual care, ongoing behavioral support, and earning the right to navigate. You said that was your model. So three quick questions. how would you like to be paid? You say primary care cap. Do you want full cap? Do you want all the risk? Do you want a global budget, or you just want a primary care carve-out? The second question is, you say in the navigation part you want to steer people to high-value providers. We're hearing a lot of that language, and what it usually means is it's code for the lowest priced provider. How are you dealing with that? How are you really looking at the quality? If you can do that. And then the third one, and this, hopefully only you can be quick. So we're at 18% of gross domestic product. What could you get it to? If Firefly held all the keys, what percentage GDP would you need?
So how would we like to get paid? In the immediate term, we'd like to get a primary care capitated carve-out. Correct. Carve-out that would include primary care, behavioral health, and some of our e-consult models. We are actively exploring moving quicker than we originally thought to a full capitated model, right, where we would bear full risk. We need to get a little bigger, have more patients to do that, but we're actively having conversations with Rich and others about when that would become an option, because we think there's a huge amount of savings if we can develop that network. The second question about navigation. So that's a really good question. It is cost and quality. For cost, we struggle to get great cost data. We do look. I've looked at the CHIA website. I've looked at some other services that use the All Payer Claims database to try to understand where are sort of lower cost providers. And we are starting in areas where we don't think there's a huge difference in quality, right? If a patient needs an MRI, we ought to be able to save, and there's a 3 to 5-fold difference in price of MRI for something fairly common. I don't worry too much about the quality there as I would, for, say, bypass surgery or something like that. We survey our patients after they see a specialist. We think there's a lot of value there in terms of the service they receive. Do you get in quickly? Does the doctor listen to you, right? Do they communicate with us? So we survey our patients, we survey our providers to say, what do you think of that care? We think that generating our own data will actually be really helpful. At the Brigham, I did a lot of work around our quality measurements. I know that they're very hit or miss and they're flawed in a lot of ways, so I don't want to put too much stock in that. There's not a lot of great metrics for specialty care, as you know. If we're evaluating cardiologists, I don't know what quality metric I would use. There's some procedural metrics around deaths for cabbages, but that doesn't help me if I just have someone who needs to be seen for coronary disease. So that's a real struggle. I think we are fortunate in Massachusetts to have a lot of very good providers, so I don't worry that if I'm sending someone to Newton Wellesley instead of Mass General that they're going to get bad care, just to use some examples. But we need more data on that. We're trying to generate some of our own. The third, what could we get GDP to in our wildest dreams? The stat that we throw around that we've heard, that we've read, maybe someone up here published, I don't know, is that there's up to 40% of healthcare spending is waste. So why don't we take, is that you? There you go. All right. Probably should have researched that before. So why don't I throw it back at you? How much of that 40% could we get? So I knew it was one of you guys. So why don't we, what's 60% of 18%? So what's that, like 10 or 11%? I mean, I don't think we're going to get down there, but we think there's, in the commercial population, a huge amount of price discrepancy in care, right? So in the Medicare population, obviously there's a huge amount of utilization differences that I think we can attack. In the commercial population, in many metro areas, there's big price differentials. I don't need to tell you guys this. You guys develop the numbers. And I don't think a lot of that is done in a rational way. It's done based on reputation, based on proximity, but not in a very rational way. So I think there's a lot of savings on price as well as utilization.
Since you asked.
Yeah.
So the OECD average is about 10.5%. Switzerland's at, I think, 13. We're at 18, and I've often said and written, we as a Commonwealth and a nation should aim at 15. I just can't imagine that wouldn't be enough to get everything we want. So that's your job.
Okay. Chris, you had a question?
So let's try to spice it up a little. Joel, you said you have 500 primes, and so that includes probably 10, 20,000 Blue Cross lives?
I don't know the number, Chris. But
Well,
yes.
I'm saying if there's 300
Let's take it as a
in each panel. So what prevents, Richard, tomorrow, and I know part of the answer is the specialists don't like it and the hospitals don't like it, but what prevents a cap tomorrow, a primary care cap, or even a primary care plus behavioral plus e-consult map deal with NEQA, where NEQA can choose where they send their hospital patients. And under a real risk deal, they have every incentive to manage that. And I know this, you've only been there a year, but alternative payment models were introduced by Blue Cross 10 years ago, and we're still just nibbling with quality measures that are flawed and very minimal incentives. So I'd love to see you two go at it a little bit and say, sure, why not?
I'll let him go first.
So, the truth is, our model does allow for a lot of what you're talking about. Is it perfect? No. There's still work to be done there, but in our AQC model, we do put groups like NEQA at risk and create incentives both for efficiency and for quality.
But I'm not talking about quality measures. I'm saying if you take behavioral and primary care, and we're going to talk about 12% or 14% of premium that could go. Could you be in a position to accept that premium for 10,000 members? And I know that there are barriers, beyond political barriers. Yeah.
So that would be my question. How do I fund the infrastructure necessary to do that job in the current environment? Am I going to get enough in infrastructure funding up front from Blue Cross to hire those team-based cares that I was just talking about so that we can appropriately align incentives? To me, that's the hurdle.
So are we going to negotiate this right here now?
It's great.
We'll be your
This is
witnesses,
real.
we'll
Yeah,
sign.
this is great.
We're under oath, so be
Yeah.
So if you give him money for infrastructure, he can actually reduce cost, and that should be good for your employer contracts.
Right. So without going into an incredible level of detail here, the AQC contracts have been in place for a long time. They have evolved over time. There is money that is controlled by the groups over time that can be used for a variety of different purposes, including care management systems and to improve primary care access and so forth, that needs to be thought of that way, right, and invested that way over time. The efficiency, I would argue that there's a lot of risk in a lot of those agreements that should create the incentive for that kind of behavior. I think we need to have more of those direct discussions with groups. I think part of the next level here for us to take it to the next level is to be able to get into that fund allocation discussion a bit. And frankly, we've had a little bit of a hands-off approach to that up through this point, and perhaps we need to take a little bit more of a hands-on approach to that. And I could see going in that direction.
So why don't you? What?
I think it's just been a matter of stepwise evolution in the product, and we do at varying degrees with different groups. I would say.
Ron, you had a question?
Yes. Thank you for coming today. I think Jeff is onto something, and as a disruptor, as your business grows, you may become nationally known. What you're trying to do. But in terms of looking at disruptors, one that we really haven't discussed, and I'm wondering what the impact will be on primary care, and that's the Walmarts of the world as they get more into this business. As a matter of fact, someone told me when we look at the disparity between what specialists are earning versus PCPs, as the Walmarts grow into this business, that disparity is going to start coming down. As a matter of fact, I was at a conference where that was being discussed, and it was actually a urology conference. And one of the urologists said, I'm a specialist. And the guy from one of the large firms said, yeah, but I'll decide what you're going to get paid. Right? Or you don't get my clients or patients, right? So what type of impact will it have? Will it improve primary care? I'm concerned that it may go in the other direction. And we're not talking about Jeff starting a business. We're talking about multi-billion-dollar firms deciding to get into healthcare, and what impact will that have?
I'll jump in on that one. I don't know if I necessarily think of them as a disruptor in a negative sense. I think of them potentially as new opportunities. It's come up by many other speakers yesterday as well as earlier today, especially thinking of the Attorney General, is, how do we connect what it is we're doing with other venues? The Attorney General talked about schools. I know school-based health centers are something that I have always been and continue to be interested in. This concept of offering service at a point of contact where it makes sense for the consumers seems like a great addition / expansion of what it is we're doing. You mentioned Walmart, and I know that on the Beacon Health level, we've connected with Walmart in other states to offer mental health services, and that pilot is going well. So, and from my own experience here in Massachusetts, connecting with CVS Health to try and improve one outcome that we've been looking at, and that's specifically trying to decrease metabolic syndrome for folks who have severe and persistent mental illness. Like, the screenings just don't get done. The screenings aren't happening at the primary care level. They're not happening at a rate we'd like to see necessarily with the psychiatrist. So why not look at how a CVS retail type of entity where the member is going routinely to pick up those medications, and often right next door is a Minute Clinic that could do that screening. Could we look at how we figure out how that type of approach can improve what needs to happen?
If I could offer, I think it's up to us to create the right environment for innovation here. We like at Blue Cross, we really like the model that Firefly has created. I should also disclose that Jeff is my primary care doctor.
Conflict of interest.
And other than the fact that he could ease up on my weight loss issue, I've really, I personally have found that to be valuable as a patient and a consumer. I think there's a lot of different things we can do, from advanced practice nurses across specialties, telehealth, McPAP, perhaps an adult version of McPAP to expand behavioral health access through primary care.
We have an adult version for pain and addictions.
Right. To relationships like the one we formed earlier this year with Atrius around bringing a different kind of way to work together between a big health plan and a big delivery system. And we expect good things from that in terms of putting the patient in the middle and really trying to design new ways of working together going forward.
I'd love to have Christina respond to this as well. I mean, there are critics that say that some of these convenience models are targeting, commercially insured patients. Where does that leave community health centers if there are no commercially insured patients going to these centers? How do we find a balance? Your perspective would be helpful.
Yeah. Well, for some health centers, they don't serve a huge base of commercially insured. Others do. I think there's nothing wrong with disruptors. It helps push the industry. Well, a lot of the characteristics that seem like you guys were seeking in models of care exist today in FQHCs. They've been decades ahead of the rest of the healthcare system, and it's okay for others to try to catch up or to try to innovate. We worry about cherry picking and the characteristics of individuals who like that kind of model. When you think about, and Don or Professor Cutler, perhaps you guys can correct me if I'm wrong, but I kind of think about healthcare in three major chunks: Medicare, commercial, and Medicaid. And in commercial, there's just, in terms of clinical pathology and sickness, there's just, I don't want to say that, it's easy to say there's not a lot of there, which is true. I don't want to minimize anyone's illness, of course. There is when it comes to older people, because as we know, when you get older, you get sick. and you need care. And when you're low income, you face a lot of health adversity because of trauma you experience and toxic stress. And social determinants of health that is part of that, including institutionalized racism and lack of health equity. So I kind of see these, Walmarts, and it's fine. It's a little bit of noise. I don't think it's really disruptive, because when we get to something really disruptive, I think that we need models that really effectuate meaningful cost change for people who are lower income or people who are older. And that nibbling around the middle in the commercial is okay, but it's not going to get GDP down to 15%.
David? I have a question for Dr. Severin and Dr. Norman. For Christina first, I wonder if you can give us an update on your experience in the Mass Health ACO, which is something that we have, as a board, had a lot of interest in. And so, A, is it working? Are you finding that you can save money on the acute end by investing in primary? Are there things that we as a board should do to help improve the way that it's operating and so on? So just any feedback.
Yeah.
And for Dr. Norman, is there, you've obviously now been in business speaking for a while. Is there good evidence that you can save money on the acute care end through the investments in behavioral health? That is, how solid should we feel about that evidence?
So early experience in the Mass Health ACO is that it has been a fantastic wild ride. and we love it. I think for our health centers, I think if they were here, what they would say about being with C3 is that it's been really hard and has created a lot of new work, replacing some old work, and even in the worst of times that we're on the right path. And that we've gotten some things right, we've gotten some things wrong, and the learnings have been incredibly powerful and is informing what we do next. So we sort of went live with the bing bang and did a lot of things at once. And so we found out after a year what was working, what isn't working, and how to pivot on that.
Can you just expand on that sentence?
Yeah, so in thinking about, let me give you something technical, in thinking about, we run a transition of care program, hospital to home. And so trying to figure out sort of the staffing model. And well, one of the earliest things we had to figure out is, how do we know when people are in the hospital? And so we've come a long way on that, and we partnered with MAHAC, the Mass eHealth Collaborative, in setting up a clearinghouse. So I think from go live, which was March of 2018 through, I believe it was end of calendar year 18, we had ingested over 500,000 ENS ADT transactions. We collaborated with our partners at MBHP so that we get a mental health feed. So we have a real-time mental health inpatient census. So we have all of this data, right? And we have all of the paid claims data. We have all of our EHR data because we aggregate those from native EHRs into an enterprise data warehouse. So we are very, very data rich. So the challenge becomes, in a very data rich environment, how do you decide which data is the right data and what is actionable and what is impactable? So we started with a transitions program where we go hospital home, approximately 30 days, attempting to decrease readmits. And we said, let's run a stratification methodology. And our methodology has been 100% of mental health. I'm saying mental health intentionally, not behavioral health, because of Part 2, 42 CFR Part 2, we do not get SUD. So I'm saying mental health. 100% of mental health, which of course could have individuals who also have issues with substance use disorders and all of the physical. We stratify 30% of the physical health, 100% of the mental health. It's a lot of admissions. Right? So this year we're saying, okay, how did that go? What was the impact? And is there sort of a sweeter spot we can get on area of focus, given that resources will always be limited? So that's one example of what we did and what we learned and how we might pivot.
And I would just add that hopefully before this 5-year project is over, that SUD, substance use disorder information, we are able to get to you, which I think will be meaningful. So the answer to your question is, I think, yes, we have been able to work on and move forward some projects and ideas that are starting to show in the preliminary data that there is a savings and can be a savings on the acute side with some of the focus on intervening with folks who have severe and persistent mental illness, in particular, connected to the earlier comment around CVS Health. We've worked connecting with Dr. Huli Tamir, who is the CMO at C3, to do a similar project with the pharmacies that are in community health centers. Most of the time, those pharmacies are owned by the community health center, and the clinical team is very interested in how the work that the pharmacist and their team can do that can add to improving outcomes for members. So if the member is going to their pharmacy and the pharmacist is able to say, there's a need for some screening connected to the medication that you're taking, let's just help you get down the hall to where the lab is. That's one less thing that the overburdened primary care team doesn't need to do, but they're able to, in partnership with their pharmacy team, have that happen to improve outcomes for the consumer. We've also, in a similar sort of hospital-focused, inpatient hospital-focused program, have been working over the past 3 years in partnership with MAHASA, the Massachusetts Housing Shelter Alliance, on a project called Hospital to Housing, which has shown an improvement in spend for folks who are chronically homeless and have severe and persistent mental illness by connecting them to glorious community health workers, who I can't say enough about. They really drive this project, making that connection. They help members do what's needed to get into permanent housing, but also equally important, they help members connect to all of the other wraparound services that often fall, into the into gaps that don't allow those members to improve their health. So those are just a couple of examples that have made some meaningful impact.
Chris?
Yeah, quickie for Joel. It sounds like Richard, I'm going to stay on this. I think it sounds like Richard's willing to negotiate. Are the incentives large enough? Is this just a yes or no?
Currently?
Are the current incentives large enough, assuming that you have the infrastructure support?
Yes.
Then why aren't there primary care caps across the board for you guys?
It's a great question. Apparently, that's a standard response from panelists to compliment you on the question. Much too complicated an answer, though, for me to get. I think part of it is the psychology and the economics coming together, if you will. So in the early days of quality contracts, physicians protested that these didn't really reflect quality and so forth. And by the way, I'm sure you've seen the figure, this country now spends $15 billion a year, or 780 hours per doctor per year filling out quality metrics, which are incredibly complicated, inconsistent, and confusing. So another shout out to you for the task force you've just created to do that.
Just doing like these little check.
Yeah, that's right. But now there's this transition to efficiency embedded in these contracts. And that's where economics and psychology, I think, collide, not coincide. If physicians were uncomfortable with quality, they are really, David and I were talking about this briefly, they really both object to and don't understand and are unwilling to take responsibility for controlling costs. And that's also reflected, by the way, in the AG report. That is, what are the incentives to drive patients to high value, quality, and cost care? So I think all of that is involved in this, Chris.
Okay, I'll get off my horse, but I'll ask Jeff unrelated but intimately related questions. If the payment systems were aligned for you to deliver the full range of services, what fraction do you think can move to text and asynchronous text and video? Just pick a number.
3/4.
Yeah, okay.
I mean, probably, right? I mean, if you think about what we do in primary care, wellness, prevention, we make people take time off work so we can talk to them about cancer prevention. It's nice for relationship building, but it's otherwise a waste of time for everyone. Chronic disease management, if you can get a blood pressure cuff, if you can get a scale, you can do a lot. And even a lot of acute care. I mean, that's where sometimes you need to see people if someone's sick, but sometimes you don't. So we think quite a lot. We see now about in the early stages, probably 50-50, but a lot of that is meeting people for the first time for relationship building, and we don't expect we'll need to meet them again in person for a while.
Thank you.
Tim,
Big
you had a
number.
question?
Yeah, just wanted to go back a little bit, particularly with Christina, talking about the workforce issues, as I think that's a critical area here. Both, I think it's identified as a strategy that's helped support this integration as well as a barrier to some of the integration. So I just wondered if we could spend just a few minutes digging in a little bit more about the care team, how that's worked, what are the obstacles been, where has it been successful, how have you seen the role of community health workers in that, and then secondly, and I guess part of it is anyone use, what do you see as the role of home care workers in your model of care?
So on the first part, specifically community health workers are a big part of the care model. And going back to some of the description and the questions about what have the experiences been so far and lessons learned, I talked about the transitions program. I would say another lesson learned, another program we run is complex care management. And the staffing model within complex care management, or CCM, was heavily sort of licensed professional centric, not solely. There were always community health workers. And one of the things that we're examining now is we're looking at tweaking that. And then looking at tweaking that, how much of the work can be moved to non-licensed professionals like professional community health workers. And I think we haven't come up with an answer, so this isn't the answer, but I think the likely answer is probably a lot. And what we see when we look at the work that's actually going on, with then the needed support and supervision, not literally supervisor, but supervision in terms of everybody supporting each other and harmonizing the different licenses and non-licenses within the primary care team. That community health workers can probably do more. Ditto with recovery coaches and peer support specialists. And then you asked me another question about the role of home care. So I'm probably, I would say, much less expert in answering that question than I am the first question. So I don't want to sort of get ahead of myself on my expertise. I certainly think that Jeff comments about how much care could be provided not physically face-to-face, which we completely agree with. I think that a lot of care could also more comfortably happen in a community-based setting, particularly in a home. And that is something that we have strived to do. And frankly, it's hard to figure that out when you have a system that's built on bricks and mortar. So that's one of our lessons learned, and one of the things that we're working on is how to put more services in the home, whether it's physically or virtually. And I would think that all home-based services, including home care, would be a big part of that. Of course, I'm sure when you look at sort of use of skilled nursing throughout the state, it looks very, very different territory by territory. So that's also something that we're trying to understand and do better, where we think there's an opportunity to do better. And then if I may, just wanted to make one comment about capitation. We're big proponents of capitation, and I think we need to be careful about not thinking that sort of good old-fashioned capitation, even what we call an enhanced primary care capitation, which might include things like primary behavioral health services too, is not a panacea for getting off of a fee-for-service chassis if the way that capitation rate is being developed is on fee-for-service claims or encounter claims. It's sort of a reincarnation of the same thing. So when we think about this and write about this, we also think about different methodologies to build up, from a population-based perspective, capitation rates if we really want to get off of a fee-for-service underpinning.
Great point. Barbara, you had a question? Or Nancy, you wanted to add?
Well, are we able to ask each other questions? Is
Go
that
for it.
allowed
It's a
without
free-for-all.
different swearing in? Well, it was just as I was listening to both Jeff and Christina talk about service and service offerings and community health workers and non-licensed services that happen, or supports that happen that are home-based and within the communities. I wonder if what used to be referred to as SMAs, shared medical appointments, and they've been around for decades and they've had different names. And I just am wondering whether or not, I used to see them as a former community health center clinician within community health centers, this ability to do like amazing, for instance, bring 20 people who have chronic pain together for a group meeting. and what happens within that meeting, not just with the practitioners who are in the room, but with the individuals that are in the room that, agree to not talk with others when they leave, but create their own little network of support. And I just wonder whether or not those, in this era of tele and virtual, if those types of entities are still happening.
I'm anecdotally a big fan of group visits. I don't know what the data show. My old practice used to do them for, I think, diabetes and a couple other things, and the patients who attended seemed to get a lot out of them. We haven't done them at Firefly, not because we don't think they're a good idea, just we haven't gotten to them yet. I think if, again, virtualizing the group visit, it almost becomes a sort of social channel, right? Social media for patients. There's a company in Boston called Patients Like Me that does this, that tries to sort of hook up patients with similar diseases, similar conditions to sort of help each other. I think there's a lot, again, I don't know what the data show yet, but I think a lot of virtue to that we're certainly fans of.
Great. Barbara, you had a question?
Yes, thanks. Jeff, this one is for you first and then for the rest of the panel. Your practice is clearly pretty innovative and cutting edge. What, in your opinion, in your experience, have been the major barriers to being even more innovative? And what would you recommend we do to fix that?
Couple things. I think one is telehealth parity and sort of payment mechanisms, right? So we do accept fee for service. Right now, we're trying to move to capitated contracts, but a lot of the fee for service contracts, don't cover much in the way of telehealth. If I'm not mistaken, MassHealth doesn't cover telehealth at all, or at least very little.
Not true.
Oh, it's not true. All right, then we should
MassHealth
talk.
is actually one of the few insurance plans in the Commonwealth that actually provides telehealth.
All right, because
Read the bulletin.
I've been trying to understand it and have not been able to see that, so I'm glad to hear that.
I'll make sure you get it.
Good. So one is more parity in telehealth coverage.
Right. We also it's also parity.
That's great. And then capitated contracts, which will enable us to use our non-licensed personnel and our sort of asynchronous visits. I think so. So I think that's really one barrier. I think interoperability, right, is a barrier. So we're independent. We pride ourselves on that. We want to be able to refer patients to the best services for them. I think the interoperability movement is still very slow, right? So we still do a lot of e-faxing back and forth, which is embarrassing, but it's the state we're in. The state, not the Commonwealth, but just that's where we are.
The situation.
So I mean, I think there are plenty of solutions to that, but I think where we would love to see this go is sort of in a sense, a two-sided marketplace where primary care physicians are referring to specialists, and there's a real marketplace for it, instead of so many primary care physicians being affiliated with big centers, big hospital-based centers, and sort of with all their sort of business sucked that way. But I think if we had a more robust marketplace, if you will, for referrals, we would see a lot better coordination and service between primary care and specialty care.
Great. We have time for one more question, Secretary.
Okay, so last Friday, the governor filed his health care bill, and my good friends in the legislature with Senator Friedman in the lead pass it, and he signs it today, which is, thank you for that, Senator Friedman. Requiring investment by both providers and payers across the board, including MassHealth and GIC, of a 30% investment combined in primary care, spending investment in primary care and behavioral health over a 3-year period. Clock is running. What do you do? Going left or right? And don't retire.
So we're very supportive of the principles around the bill. I really, in listening to the commissioner from Rhode Island's talk earlier today, thought the principles that they laid out made a lot of sense, starting with, in fact, it was a little lower on the list, but starting with what other incentives we're trying to create. And then the details matter on things like this, of course. So I think we need to understand a little bit more about what the baseline looks like. How do we define it?
What's the detail you would want to know?
I would want to know a little bit more about how are we defining primary care spend. I want to make sure it's inclusive. I like the idea in Rhode Island that the vast majority of the spend was in payments outside of fee-for-service. I think that's going to be an important part of the discussion here as we work to shape the bill.
Christina?
So I think it would solve some of the perennial problems we experience around recruitment and retention, right, which is huge. I think it would enable all health centers to get to sort of a gold standard on BHI, SAMHSA level 6, to take one example. I think we'd also say, okay, this is our opportunity. PCMH has been great, but we all know that there's an element of PCMH that is really about clinical care, and there's an element of PCMH that's about administrative boxes, right? We're going to develop our own PCMH standards. And it will include things like universal screening, referral, and closed loop on SDOH concerns, housing, food, et cetera. And other types of these BHI standards, which are not part of the prevailing PCMH standards today.
I too agree with what's been said around many of the positive components of the governor's bill. I think he was kind. You were all kind in making suggestions, for instance, around psychiatry, accepting many different forms of payment versus a mandate or something that sounds like that, but I understand why that may be there. But, you know, I want to maybe connect my answer to Commissioner Blakeney's earlier question around barriers. I feel like sometimes, you know, we make these steps forward, but we often get in our own way as far as being able to advance. And I think some of that has to do with what I often refer to as the culture of how it is we do what we do. Like, so often we've been doing it for so long, the way we've been doing it, we can't think of doing it in a different way. And so I get excited about thinking about things differently and trying to use components that are in bills like the governor's to move that agenda forward.
Yeah, so we're big fans of what we've heard about the plan. Certainly increasing funding rates for funding for primary care and telehealth would be music to our ears. And, you know, as I've said, and I think a lot of people here have said, just pushing the non-fee-for-service based payment would be huge for us, and we think moving in the right direction. And there may not be one payment system that's right for everyone, at least at the right pace, at the right cadence. You know, we know that we're ahead of where some are. We also don't have a hospital and don't have a lot of the other things that other providers do. So it may not be a one-size-fits-all approach. And I would think that's okay and would promote experimentation.
I would just echo what others have said. I think the devil will be in the details, very much like the outline that was proposed. What are we doing with fee-for-service rates? What are we doing with hospital rates? What are we doing with telehealth? How can we, back to your comment, do more with our colleagues, the advanced practice clinicians and other licensed and non-licensed people? But I think it has great promise.
Great. It's a round of applause for our panelists. Really appreciate the breadth and depth of all of your remarks. We will take a lunch break and reconvene at 1 o'clock.
Great to see you. Nice job.